मैम वर्क नहीं कर रहा ये एनी डेस्क।
Yeah. Good morning, everyone. You all can hear me, na? Hello. Hello.
Yes, ma'am. Yes, ma'am.
Yeah. Good morning, everyone. I am Dr. Shilpa Morekar. I am the lab director at NM Medical Center, Mumbai, which is a diagnostic center. And I would at the outset like to thank Melap and Dr. Neeraj Jain for giving me this opportunity to come on this platform and talk to you all about quality control in hematology. Next, please. Next slide. Yeah. So, in laboratory medicine, healthcare plays a very important role. The quality of clinical laboratory service is critically dependent on the quality management of the total test process and giving accurate results with interpretation and appropriate reference interval and clinical decision. Next, please. Now, these are the terminologies which we most commonly use in our routine lab process, but we should know what are the difference between the two. So quality assurance, quality control, these are the terminologies which we normally talk about. So what is quality assurance? Quality assurance is an overall management plan to guarantee the integrity of the data, and it assesses how your lab can improve the reliability of the test results. In contrast, what is quality control? Quality control is previous slide, please. Previous slide, please. Yeah. So quality control is a series of analytical measurements used to assess the quality of the result, and quality control ensures that the results generated by the lab are correct. Next slide, please. Next, yeah. So when we talk of approach to quality control in hematology, how does this differ? This differs from that in clinical chemistry because the hematology analyzers that we are using are multi-parameter instruments. That is, it gives us, in hematology, we have multiple tests like CBC, you have hemoglobin, platelets, RBCs. So these are performing many tests as opposed to the chemistry analyzers, which perform only one analyte at a time. In this, we use cell suspension, and therefore the problems arising from this are unique and require thorough understanding. So in hematology laboratory services, what all can be there in which we can see the quality control? That is general hematology, specialized hematology, coagulation, flow cytometry, molecular hematopathology, and blood transfusion and stem cell biobank. Next slide, please. Now, lab accreditation or accreditation is the most common word that is used all across. Now, do we really need lab accreditation? One might say that I am following daily QCs every day. I know that my lab is doing properly. Then why do I need to go for lab accreditation? You may say so, but what does lab accreditation help us in person? Accreditation is a process by which formal recognition is given to a laboratory to perform tests. The NABL certification demonstrates that a laboratory is capable and competent to carry out its specified scope. It provides feedback to the laboratories that they are performing their work in accordance with the international criteria. In many advanced countries, external accreditation is mandatory. However, in India, external accreditation is a voluntary process. You may or you may not go in for accreditation, but going in for an accreditation always gives a boost to the lab as we get a recognition from a third party saying that the work that you do is in concordance with the standard. Next, please. Now, when you're getting ready for accreditation, what is necessary? The quality management, the quality control, and the QSP program must be clearly defined and documented in the standard. It must ensure quality through all phases of testing, that is pre-analytical, analytical, and post-analytical. It should be capable of detecting problems and offer solutions for preventive actions and corrective actions. Now, what do I mean by preventive action? Suppose if you have a sample of platelet where the platelet count is low, you would want to know whether this particular patient has come to you before by checking the delta check. Now, suppose if the platelet count 1 month back was normal, you would want to find out, taking proper history either from the patient or from the clinician, whether he has clinically some symptoms. And if not, you will do a slide review and release the report. What do you mean by corrective action? Now, suppose a report has already been issued and there is some issue or some wrong report that has been given. In that case, you will amend the report. Now, whenever an amendment is to be made, you have to be sure, you should convey to the user, that is the patient and the doctor, which parameter has been amended. And the amended report should mention that this report supersedes the previous report for the amendment made for a particular test, maybe a hemoglobin or CT. So that has to be mentioned in the footnote. Next, please. Next, please. Now, when you have technologies working in the laboratory, you have 3-4 technologies working in individual departments. How can you be assured that all technologies will work in the same way and same pattern to assure full result quality? That usually does not happen when you have multiple people. Hence, we need a standard operating procedure that should be written comprehensively, and it describes all processes that has to be carried out in that particular department. Standard operating procedure is essential for ensuring uniformity in the lab procedure. Next, please. Next, please. Now, what are the components of quality assurance in clinical laboratory? Quality assurance is comprehensive and covers all aspects of the laboratory testing, that is pre-analytical, analytical, and post-analytical. Next, please. Next slide, please. Now, when we talk about pre-analytical, 70% of the errors that happen are in pre-analytical. This is mainly because of the greater human intervention that occurs in pre-analytical phase. Now, what are the pre-analytical errors that can occur? A wrong patient ID. You have got a wrong sample with a wrong barcode written. Specimen collection. Use of appropriate coagulant should be used. Suppose if for PP, prothrombin time, on EDTA has been collected. This is a pre-analytical error. The order of draw should be followed. You are seeing on the right side of the screen the order of draw, wherein initially the blood culture, then the citrate. All these orders have to be followed to ensure that there are no pre-analytical errors. Now, once the samples have been taken, the transport of the sample is very important. It should be transported in such a way that the stability of the blood is maintained, and the transport should be done in a timely manner. Specimens of hematology test must be free from clot. Specimens of coagulation should be separated, double centrifuged, and frozen as soon as possible. Substantial evidence indicates that major area of improvement in laboratory medicine is in the pre-analytical phase. Next slide, please. Next slide, please. There are some more pre-analytical tips that are helpful to see that you give a good quality report. Whenever you take the sample with anticoagulant, it is necessary that you invert the sample 6 times so that you get a proper result. Results on unmixed specimens reveal a significant decrease for the red cell count hemoglobin, and hematocrit. The ICSH currently recommends use of K2-EDTA. Previous slide, please. Previous slide, please. Please go to the previous. Yeah. ICSH recommends K2-EDTA to be taken for hematological test. Whenever there is a lipemic sample of CBC, this can cause erroneous results for sample for tests like hemoglobin, MCV, and MCH. Now, suppose if you have a visually diluted EDTA sample, what would you do? Initially, you will see with the delta check to see whether this patient really has come before and has got a low hemoglobin count. If not, you will try to find out whether this sample has been collected from IV site. Because you know that if samples are collected from the IV site, there is always a chance of the sample getting diluted, as a result of which you will have wrong results. Now, whenever you run CBC, many a times we see that there are 4 agglutinins present in the patient. How do we get that? You will see that with a flag in your HCP. Now, in that case, you will have to incubate the sample and then retest it in manual mode and mention it into the report that cold agglutinations are present, and hence this sample has been processed after incubation. EDTA has to be specifically checked for clot before you put it onto the analyzer. Next, please. Next slide, please. Coming to coagulation samples, it is said that we need to use 3.2% sodium citrate instead of 3.8%, because when the samples are collected in 3.8% sodium citrate, there may be an overestimation of prothrombin time and APTC, and hence it has to be collected in 3.2% sodium citrate. The tube should be adequately filled. It should be filled up to the mark, because underfilled or overfilled tube may also give you wrong results. Coagulation test has to be performed within 4 hours of collection, and you should be sure that platelet poor plasma should be rechecked every time you have a change. Next slide, please. Next slide, please. Okay. Now coming to analytical phases, what are the factors that influence the quality? If you see here on the slide, there are multiple parameters that can affect analytical phase, starting from proficiency of the person. The person who's running the test or who's using the analyzer has to be educated, and adequate training has to be given. You need to check the competency of the person. That person has to attend CNE. Coming to reagents and stability integrity, here you will see that you need to have desired quality of continuously available reagents and validation of the reagents. Next is the equipment. The equipment that you use has to be comparable and should meet all your technical needs. Then you need to document all this and use of appropriate control. Now, in the next few slides, we will see the controls, how the use of appropriate controls helps to give you adequate results. Next slide, please. Calibrators and controls. These are commonly used whether we are working in the hematology department or biochemistry. So what are calibrators? Calibrators are substances with specific concentration, and it is used to adjust customer system to an established reference system, and it gives a reference point for the instrument to adjust. Whereas controls are substances which are similar to the patient sample that has established concentration, and controls are used to ensure that your procedure and instrument is working properly. Please make a note that controls cannot be substituted, calibrators cannot be substituted and used as control. Next slide. Next slide. Now, if you look at this, we have to know that what is accuracy and what is precision, because this is very, very important in analytical phase. If you see here in the center, you can see that the points or the values are accurate. So what is accuracy? Accuracy is a measure of how close the reported test results are to the true values, which is typically a target and it is defined by gold standard. Vis-a-vis, if you see on the right-hand side, you will see that the points are at one extreme side. So that is precision. So there is a precision here. What is precision? Precision is measure of how close the test results are to each other when they are repeated multiple times on the same sample. So the right picture shows that there is a precision, however, there is no accuracy. And on the left, there is neither precision nor accuracy. Next slide, please. Next slide, please. Now, how do you check for accuracy? Now, when we check for accuracy, we use the calibrator. Now, what is a calibrator? Calibrator is a reference material with a known value, which is traceable to a document issued by a certifying body like CLSI. Calibration set a base level for the analyzer. It is achieved by arriving at the calibration factor. The calibration of the analyzer's frequency can be either 6 months or a year, depending upon your company, the analyzer from which company you are using it. Calibrators can be used to check the reproducibility, carryover, calibration run data, and calibration verification. Next slide, please. Coming to analytical phase in hematology lab, we did mention about QC. Now let us see a little more in detail about QC. Now, whenever you are talking about QC, you have internal quality control, external quality control, and instrument maintenance. Internal quality control procedure for individual instrument or inter-instrument comparison may include use of preserved or stabilized whole blood control. We have 3 levels of control in hematology. Retained patient samples can also be used, or combination of the above can be used. In hematology, you have a multi-parameter control. That is, from one control, you get all your data, that is from hemoglobin, from hemoglobin, RBCs, platelets, your indices, everything. So it is a multi-parameter control. Next slide, please. Next slide, please. Coming to right analytical, for prothrombin time, we all know that for prothrombin time, ISI value is very, very important. ISI value should be appropriate to the particular prothrombin reagent and the instrument used. Calculation of INR depends upon your ISR. So what we do here in prothrombin time is that we take 20 normal males and females and we derive an MNPT. Now, depending upon this MNPT, your biological reference interval will always change. There are checks of patients' reports for correct INR calculation, and they should be done in the following circumstances. That is when there is a change in lot or a type of PT reagent, change in instrument, establishment of a new prothrombin reference interval, change in INR calculation, and at defined interval intermittently in absence of the above. Reference interval for prothrombin time and APTT should be current for the reagents and lots they are using. So always remember that whenever there is a lot change, MNPT has to be changed and the new biological reference interval has to be incorporated into your report. Next, please. Next, please. Now we have done all this. We are running the QC, but just running the QC, is it important or we do need to monitor it? And how frequently do we monitor? Suppose you are running the QC every day and at the end of the month you are going and checking the QC. Will it help? No, because the QCs have to be monitored by your LJ chart or Levy-Jevons chart. And please remember that these LJ charts have to be reviewed regularly on daily basis. Now, when does the control value indicate a problem? What are you going to do? You're going to use a Westgard multi-rule for the quality check. Westgard multi-rule takes care of 95% of the control value within plus or minus 2s. The LJ chart and Westgard rules are commonly applied when we use two levels of control, and it allows determination of whether an analytical run is in control or out of control. Next, please. Next slide, please. Now, Westgard rules, we all know that they were developed by Dr. James O. Westgard based on the statistical concept. The most common Westgard rules that we use is 1-2S, 1-3S, 2-2S, R4S, 4-1S, and 10S. Now, these rules allow to determine whether our analytical run is in control or out of control. Now, whenever we are talking of errors, what are the common errors that occur in the laboratory? The systematic error, that is avoidable error that can be avoided due to control variables in the machine. So, moment you pick up something, the systematic error can be taken care. The next error is the random error, which is an unavoidable error that are impossible to eliminate. Next slide, please. Now coming to Westgard rule, the most commonest one that we use is 1-2S. Please remember that 1-2S is a warning rule. Now, if you see on the graph, there is a yellow plot that says that one control result is falling outside plus or minus 2S. This is an alert. This should give an alert to the technician that there is a problem. This is a warning rule, and then you can see what is going on in the next day run. Next, please. Coming to Westgard rule 2-2S. Now, if you see here in the circle, the yellow dot, there are two consecutive control values for the same level, which is falling outside plus or minus 2S. In this case, the patient's results cannot be reported, and this requires immediate corrective action. Next, please. Next slide, please. Yeah. Coming to Westgard rule R4S. Now, if you see here in the red circle, you are seeing two yellow dots, which are exceeded by the means of one on the upper side above 2S and on the lower side minus 2S. So the one control exceeds by minus 2S on one side and plus 2S on the other side, and the range between these two results will therefore exceed 4S. This random error has occurred and the test run has to be rejected. Next slide, please. Next slide, please. Coming to 4-1S. Now, if you see here in the down, the dots marked in green, here you are seeing that there are 4 consecutive QC runs on one side outside 1S. Now, why this rule is important? Because here on 4 consecutive days, even if it is 1ST, on 4 consecutive days, there is violation. So both the levels of controls have consecutively been outside in 1S. Next slide, please. Next slide, please. Coming to 10x. Now, if you see here on the top, in the circle that has been given, 10 consecutive results for one level of the controls are on one side of the mean. Now, what do you mean by that? Suppose if you are not daily checking your LJ chart, in this case, there is a positive bias that is continuously there on your control level. And hence, we say that your LJ chart should be seen on daily basis so that you come to know whether there is a trend or bias on either positive or negative side. Next slide, please. Next slide, please. Again, there is a trend here in the circle. You are seeing that initially the controls were in 1S, going up to 2S, and then reaching up to 3S. So if you don't see this, the controls are moving in one direction, heading towards an out of control value. This is a systematic error, and hence we said in the first slide that systematic error can be corrected if we keep a QC. Now, what are the next slide, please? Next slide. Next slide, please. Okay. Now, what are the other supplement quality checks in CBC? Moving averages. Most CBC analyzers now come with onboard technique of moving average. Apart from that, you can do a retained patient sample. Use of a retained patient specimen alone is inadequate. Please note, once again repeating, QCs cannot be, you need to have to run the QCs. A retained sample cannot be replaced as a quality control. Sampling mode comparison. Different modes may involve a different sample path before analysis. When samples are analyzed in one or more modes, it is important to ensure that the modes are functioning properly. Inter-instrument comparison can be done if you have two equipments of the same company or different technologies. The inter-instrument comparison should be done and acceptable range should be established. Reportable interval and linearity. Now, what do you mean by reportable interval and linearity? Every instrument gives you a linearity. Linearity is saying, now suppose your CBC analyzer gives you a linearity of 4 lakhs. Now, if you have not done a linearity study, how would you know that a report or a patient sample which is giving a report of 1 lakh or 1.5 lakh or 2 lakh, how confident would you be if to release that report to ensure that your machine is working properly? Hence, as and when possible, a linearity check that is claimed by the company has to be verified. Coming next to smear examination criteria. The smear examination criteria should be clearly defined and implemented. Next slide, please. Next slide, please. Now, what is retained sample? Now, if you see here, retained sample, patient's repeats can be used as retained sample. Now, suppose if you are running 2 controls in the morning instead of 3 controls, you can use a retained sample after 8 hours to just check whether your things are going on properly or not. This is an additional step in IQC, and suppose at times or for 1 day or 2 days, your controls are not available. This method of retained sample can help whenever your control material is not available. Standardization of your equipment has to be done. Now, if you see in the graph on the right-hand side, you have got types of all your tests. So that is a good concordance. And on the left-hand side, you are seeing the points are all scatteredly plotted. So the concordance in this side is not good. Next, please. Next slide, please. This is the example that I have given of the retained specimen testing that we do in our lab. So every day we try to, whatever samples are run in the morning, we try and do a retained sample in the afternoon. We done 2 controls in the morning and a retained sample in the afternoon. Next slide, please. Next slide, please. Now, what is calibration? Do we need to calibrate the instrument? Yes, calibration rules are followed in hematology whenever there is a change of reagent, whenever there is a outlier that you see in your quality control, after a major repair or preventive maintenance, and when recommended by manufacturer. This means that if 1 day your controls are out, you don't have to calibrate. So calibration has to be kept as a last option. You first do your root cause analysis. I'll show you a slide where how to do a root cause analysis. But these are the following calibration rules when we have to do the calibration. Next slide, please. Now, lot-to-lot verification. This is commonly seen and spoken about in all the labs. But do we really know how to do a lot-to-lot verification and when it has to be done? So lot-to-lot verification has to be done for all the reagents and controls. Now, this is the format of our lab that we have kept, where we do a lot verification of the old kit and the new kit. You always remember that lot-to-lot verification, like I said, has to be done when the lot changes. However, once in a while, we can also do a lot-to-lot verification when there is a change in shipment. Now, suppose we always, to avoid the cost, we always ask for a lot of, for a, how do I put it, many controls of the same lot so that the cost is avoided. But once in a while, you should also do lot-to-lot verification when there is a change in shipment, because the change in shipment can cause change in the temperature, which can cause variations in your result. So if you see here in the tabular form, you have old lot result, new lot result, the deviation and the acceptable deviation as per NABL price. Next slide, please. Next slide, please. Coming to slide review criteria. Is it essential to do slide review criteria? Most of our analyzers are now 5-part and 7-part that help us as pathologists to kind of normally review the ones which are normal and give away the result. But you can do that only and only if you have laid down slide review criteria. International Standard for Laboratory Hematology have got beautiful guidelines for slide review criteria. You can take a few and incorporate those in your laboratory. On the right hand side, I have given you an idea of slide review criteria that we have used in our laboratory. That is the screening criteria, quantitative screening criteria, qualitative screening criteria, and the suspected flag. Next slide, please. Now coming to external quality control. Now, what is external quality control? That is nothing but your proficiency testing. Proficiency testing are something wherein we get the controls from the samples from outside. We run the samples and we are compared with the peer group. There are multiple proficiency testing programs that are available. However, if for any particular analyte or assay, if there are no external quality control programs available, then you can do an inter-lab comparison. That is inter-lab comparison by sending your samples outside to a NABL accredited lab. Now, suppose if you're doing a test which no other lab is doing, in that case, you will do a split sample analysis. That is, you will split the sample into two and ask your technologist to run that data and you will maintain the data. Next slide, please. Next slide, please. There are few quality control programs that are available, like for hematology. Next slide, please. That is for hematology, we have AIM, then you have Biorad, you have Randolph, you have CMC Vellore. There are few Indian names like RML, where all these programs are available. You have to ensure that the program that you are taking for or you're enrolling for has to be an accredited program. Next slide, please. Next slide, please. Next slide, please. Now, I said that we are running IQC and NICWAS. Now, what will you do if you have a daily non-conformity or daily NCs that is occurring on your day-to-day basis? A common incident, complaint, or accident has to be reported into the format, and this format has to be submitted either to your deputy quality manager or quality manager, who then does the root cause analysis and will evaluate the potential risk that can occur and how you are going to prevent the same non-conformity. This has to be discussed in the lab meeting. Next slide, please. Next slide, please. Now here, if you see, this is a incident report for daily QC. This is the form that we use whenever you have a daily QC outlier. The department, the parameters, which wildcard route has been violated, what has the remedial actions been taken, and who has done it and who has approved it. Now, what will you do if there is a QC outlier? Whenever there is a QC outlier, you will stop running all the tests. You will do the root cause analysis, find out what was the problem, and then restart. Now, suppose if your QC outlier, there is a QC outlier in the afternoon after which you have done the root cause analysis. Randomly pick up any few samples from the previous to the ones where the outlier was and rerun it again and see that the QCs are following and the samples that you have run before and the results that you have given are not. Next slide, please. This is the monthly EQUAS outlier form of our laboratory. In NABL 112 also, you will get a detailed QC format outlier. Also, Biorad gives you in depth the QC outlier form. This is the one which we have made depending right from when the sample was received, who has received the sample, who has prepared the sample, whether there were bubbles, whether there was some other technical problem, whether there was typographical error. So we do the root cause analysis and come to whether it is a systematic error, random error, or a typographical error, and what corrective actions have been taken, and who has done it, and who has approved it. So this form I have put just for you to have an idea that whenever you are getting an EQUAS program, just running the EQUAS program is not important. You have to see whether there are any outliers, and if there are any outliers, you have to make a record of it. Next slide, please. Next slide, please. Now, what is sigma matrix? Sigma matrix is a new concept mainly used in biochemistry, but nowadays also used in hematology. Sigma matrix was used in the automobile industry, and now it has become like a quality management and improvement tool, a method to qualify and minimize the defects. Now, it is said that a process with Six Sigma, the performance produces only 3.4 defects per million opportunity. The name Six Sigma refers to the ideal goal when 6 standard deviations can be defined. Now, how do you calculate Six Sigma? Six Sigma is nothing but your total allowable error minus bias divided by your CV percentage. Next slide, please. Six Sigma matrix is a widely applied quality indicator and has gained use in laboratory medicine. Six Sigma matrix more than 3 is generally considered as an acceptable performance. So you can see the table here on the right. You can do Six Sigma for each analyte right form, hemoglobin, HCP, RBC. And if your Six Sigma matrix is more than 3, that means you are on a good control platform. Next slide, please. Next slide, please. Coming to post-analytical. According to CDC, 14 billion lab tests are ordered annually, and 60 to 70% of medical decision depends on your lab results. That means, please note that whatever we are doing post-analytically can give up to 60 to 70% decision depending upon what we are releasing the report. So now what is the purpose? You will verify or to see that verification and correctness of the tests are done. That is, you do proper delta check, you give the right interpretation, and you give the normal reference interval depending upon age and sex, the age, male and female, and whether the sample that you have received is from a child or an adult. Maintain the turnaround time, give proper correlation of lab findings, proper communication with the caregiver, give wherever there are critical results, has to be intimated to your clinician. Next slide, please. What is risk management? Risk management is something that has come up new, and it is very important, a process that involves participation in what could go wrong in assessing the frequency and the consequences or the severity of harm they can cause. Next slide, please. Next slide, please. Risk assessment, like I said, is a new concept. When it is applied in proper way, it has got a greater impact on patient safety It is aimed to minimize the harm to the patient by developing a system that can discover the potential error before it affects the patient management. It is comprehensive and covers all the analytical stages of the laboratory. That means you can do risk assessment in pre-analytical, analytical, and post-analytical. Next, please. Next slide, please. So this is the risk analysis or the risk assessment that we have done in our laboratory. On the left-hand side, you can see the risks that are occurring in pre-analytical, analytical, and post-analytical, the probability that can occur, the severity, and then the final score. On the right-hand side, you can see the risk acceptable matrix. Depending upon the probability, you can divide the risk into negligible, minor, serious, critical, and catastrophic. So this risk assessment analysis has been given more weightage in the new standard of ISO 15189-2022. Next slide, please. Next slide, please. Coming to the last, that is the lab information system. Either you have a manual transcription or you have LIS in your laboratory. Whatever is the mode of reporting, there has to be error-free reporting. If there is a manual transcription, then you have to see that whatever has been typed manually has been verified by someone. If you have an LIS in the system, the LIS is validated by the vendor. It is the duty of the lab to verify the LIS that has been given. As per NABL 112, the LIS verification has to be done on minimum 10 samples, and it has to be done at the frequency of 6 months. So in a year, twice you do your LIS verification to see that you are giving accurate, timely, and competent and correct results. Next slide, please. Next slide, please. So in short, I would like to summarize that whenever you are talking about quality control in hematology, it should have an access right from your pre-analytical, analytical, and post-analytical. Because like we saw, 70% of the errors can be taken care of if your pre-analyticals have been addressed. Coming to QC, whenever you are running QC, many times we see that the QCs are run and just kept. There is no one who is reviewing it or verifying it. And hence it is important that whatever QCs you are running, whether it is a daily QC or whether it is your EQUAS program, it has to be supervised and verified by your supervisor. So thank you very much. I am sorry for the technical glitches that we had in starting the program. If we have time, I think I am ready to take the questions if we have time, Saurabh.
Yes, ma'am. 2, 3 questions there in the chat box, please see.
Risk management. I'll take first question here that I can see. Risk management, when is it to be done? Risk management should be a regular process in your laboratory. Like I said, it has to be done in all your phases of pre-analytical, analytical, and post-analytical. So right from your sample accession, you have to keep your eyes open and you have to train your staff to see that whenever they see something which is not normal or abnormal happening regularly also in your lab. I would like to share one example where since I am an assessor, I had gone to an hospital and there I saw that they have done a risk assessment for patients whenever there is you see the floor has been mopped. So they had also included that as a risk management. So risk management can be done at any phase and for any process. What about risk analysis when developing a new process? Yes, this would also has to be taken care of because, like I said, risk analysis is also done in analytical. So whenever there is a sample or a new process or a new test that is happening in your center, a risk analysis has to be done. Next question is how to apply a fishbone tool. Risk assessment, risk management, and fishbone is a very, very elaborate and a very long lecture. Saurabh, I would like if you can share. I think this question is asked by Zinu. So if you can share me her number, maybe I can talk to her one on one, because that is a very long. That's a lecture. It's an individual lecture in it,
Sure,
on its
ma'am. We'll
own. It
share
will be
a
really
share
different.
a number
Yeah.
later. Yeah.
Any more questions
I
that are
think
there?
then, ma'am, we'll proceed with the next presentation. Thank you.
Okay. Thank you, Saurabh, very much. And
Thank
thank you all for your patience hearing. And I'm once again sorry for all the technical glitches that happened. Thanks a lot.
Sorry for that. And so, as Dr. Shilpa Morikar in the beginning told about the quality control in the hematology, where we are dealing with lot of numerical values as such. However, the scenario is completely different in histopathology and cytopathology. It is more subjective in nature, and hence the quality control in histo and cyto is slightly different from what we see in routinely in hematology and clinical biochemistry. So there can be bit respite in the sense that you don't have to really deal in much more statistical techniques to know or to apply the statistical tool for the quality in histo and cyto. So coming to my presentation part, let me start with the definition. Histopathology, as we know, is an art of analyzing and interpreting the shapes, sizes, and architectural patterns of the cells and tissues within a given specific clinical background, and a science by which the image is placed in the context of knowledge of pathobiology to arrive at an accurate diagnosis. Quality assurance is the systematic monitoring of the quality control results and quality practice parameters to assure that all systems are functioning in a manner appropriate to the excellence in the healthcare delivery. This definition I have taken as a reference from the CAP. So basically, as you have learned in the morning also, that the important aspect for the quality in any discipline, right, starts from the pre-analytical up to the post-analytical stage. Now, same is the case in histo and cyto. So even the pre-analytical phase, analytical phase, and post-analytical phase, all phases are important from quality controller point of view also. Now, assessment and implementation of the quality control is more difficult in histopathology due to some inherent qualities or inherent nature of the discipline. As there is lack of the objective numerical data, we have to depend more on the subjective findings, descriptive nature of the reports, subjectivity, individual judgment and bias, and non-uniformity of the reporting patterns. So we'll be discussing that in a bit. So let's come to some of the variables that affect uh, the results in the histopathology. So what are those variables? So educational background and training of the laboratory personnel. When I'm talking about the laboratory personnel, it doesn't mean not only the technicians, but the doctors as well. How they are trained, how is the knowledge, all that eventually matters for the quality. Conditions of the specimen, how they are being received, whether they are fixed or not, whether any transport media is being used or not, all those things definitely matters. So what are the controls used in the test runs? As we run the internal quality control in hematology and biochemistry, now similarly, we run the internal quality controls over the slides as well. Reagent part, how we are taking the all the reagents and chemicals, how we are taking care of all our equipment, how we are interpreting and giving the results, how we are transcribing the results, how we are reporting it, whether we are whether we are including any standard format for the reporting or not, as per the recommendations. That all matters for the when we talk about the quality. Now, for the simplicity, as I was telling, I have um, grouped them in the three phases of the operations: pre-analytical, analytical, and post-analytical. What does pre-analytical phase consist of? So all the processes which are involved up to the submission of the stain slides for analysis are grouped under the pre-analytical part. So it includes infrastructure part, manpower part, equipment, sample collection, requisition details, demographic, transportation, fixation, and all that. Labeling is something very, very important. And if we see, most common cause of the error in the pre-analytical phase is the labeling errors. Be it histo, be it cyto, or be it hemat or biochemistry. So labeling is something very unique and should not contain any error. So correct patient identification by the unique accession number that is traceable to the specimen, and it should be traceable throughout the process, is very, very important. So nowadays, whenever any sample is collected, unique ID is provided, and even the barcode is generated, and that barcode is tagged to that unique ID and the patient details. And once that is barcode is followed in the lab through all the aspects of the examinations, then the chances of error is nil. So avoiding errors such as the wrong identification of the anatomical location as well as the laterality of the biopsy, whether it's right or left, this is equally important whenever we are talking about the histopathology or even the cytopathology specimen. So where I have done the FNECs maybe from the right sided cervical lymph node, but then I have written on the form as the left. And similarly, operation has been performed on the right side, but on the histopathology requisition form, it has been written as the left. So this kind of error should not happen. So requisition forms are always used for the histopathology, and we some people call it TRF, test requisition form, some call the referral form, some call the requisition form. So whatever the terminology is being used, but basic idea is to give the details pertaining to that specimen on the histopathology form. So it is very important that this form is filled up properly. There should be space for the entry of the relevant clinical data. As we, being laboratory professional, we all know that how important the clinical data for us whenever we are interpreting the results. So it's always preferable. So in the form, if we insert some check boxes for the better clinical compliance, so it becomes easy for the clinicians to tick those boxes, and hence the time taken is quite less. Dialogue with the clinicians about the importance of properly filled form is needed, because this is the most frequently um, nuance which frequently comes across among the pathologists, that the form is not properly filled up. So it is our duty that we develop the good rapport with them, and we are able to convince them, make them understand that the properly filled form is very important for us if we want to give the good report. And if the clinical data is not available, the laboratory should take the initiative to extract the relevant data either from the treating physicians or the hospital files. So what are the steps to achieve the proper control of the pre-analytical and analytical process? So standard procedures for the sample accession, identification, acceptance, rejections, gross examination, and sampling, and all the steps that follow must be documented. So this is something very important, that we have the proper SOPs for the pre-analytical phase, how the sample is to be collected, how it is to be received, how it is to be numbered, what are the sample acceptance criteria that should be clearly written and displayed and should be known to the person who is receiving, how the gross examination is to be performed, which is frequently done by the pathologist. So they should also have some ready reference material displayed in front of them, or the file there. Whenever in doubt, they can go through that. For example, if we are getting the sample of the prostate, now how much prostate is to be processed, or the blocks, how many blocks should be made, and how much sampling is to be done. Now, similarly is the case for the other. We all know as a pathologist that we have a tough time when we are dealing with any radical mastectomy specimen, looking for the lymph nodes, carefully searching them and then slicing them and making grossing them. So these are all part of the gross examination, which should be well known to the person who is doing the gross examination. As we all can understand, even the simple error in the grossing, where we fail to take the proper section, uh, can result in definitely disastrous reporting on part of the pathologist. So it's very important that these aspects are to be taken care of. Planned changing of the chemicals used for the processing based on the number of the tissues passed through. As we all know, for the processing, we need the all those alcohol in different concentrations, and it is to be ensured that we make a proper planning at how much after how much processing of the samples these alcohols are to be changed. So that log is to be maintained whenever you are changing. And again, it will depend on your workload. So if your workload is more, probably you have to change it from every day to up to even a week. So it all depends how much the work. So accordingly, one should make the protocol for that, and even keep a proper record of that in the form of the log. Fixation is something very, very important in histopathology. And as we all know that generally all samples for histopathology are submitted to the lab in fixative media of 10% formalin saline, sometimes 10% neutral buffer formalin, which is ideally recommended whenever we are going for the ISC. And as we all know that it is to be done immediately after surgery. Generally, the volume of the fixative media is about 10 to 20 times the volume of the specimen. And large specimen, if we can slice them and then put them in the formalin, probably better fixation takes place. And intestine, when the intestine sample is coming, is better to cover that with the cotton wool soaked in formalin. And for testicular biopsy, we know there is a separate fixating media that is called the Bowens fluid. Equipment which we are dealing in the histopathology are equally important, that we should have a good quality microtome which is serviced regularly. This is very important because now we are cutting the sections for some tissues like lymph node, where we want to have a minimal thickness of the section. So it is very important that our microtome is serviced up to date. Even the periodic calibration of the micrometer is available, so that even we can know about the section of thickness. Periodic cleaning and lubrication of the equipment. Tissue processing care should be taken not to induce tissue artifacts due to improper processing, sectioning, staining, and mounting. All these steps can give rise to some tissue artifacts, and when we see under the microscope, it causes problem for us to report. Appropriate labeling of the stain slice is something very important. Appropriate size so that it does not project beyond the slide or the cover the tissue section. So identification should be legible and should ideally carry the name of the laboratory as well. Using barcode labels, one can incorporate demographic data such as the name of the laboratory, name of the patient, laboratory ID number, and the date. So all this is possible, but it's very important that proper labeling of the slide is done. Running of the control, as I was talking in the beginning, is something very important. All ideally, whenever we are using any spatial stains or even for the routine stains, one slide should be stained and looked under the microscope whether it is up to the mark, whether the staining is okay or not for hematoxylin, eosin, etc. For spatial stains and immunohistochemistry, it is very important that along with the section in question, we also run the quality control tissue, or make the slide of the quality control as well. Because unless we know our quality control is working fine, we will never know and whether we are able to report it correctly or not. And we may land up in reporting false negative. So it's very important that we must use control slides along with the routine one, and we must keep them as a record. So whenever any audit happens, we can produce them and tell them, see, we are running these types of control, and hence we are sure of our staining and reporting. So for routine HNE staining, the laboratory may identify one tissue block with a good mixture of hematoxylin and eosinophilic tissue. Any section from the cervix, fibroadenoma, etc. It's a good control. You can make a proper block for them and keep it that for the control purpose. And every day you can cut one of the block and then use that. Some of the important post-analytical aspects are traditional laboratory approach to the post-analytical phase involves the report generation without any transcription error, report transmission and dispatch to the right person, and storage of the reported material as well as the reported data, and safe disposal of the specimens thereafter. So it's very important when we are reporting whether we are following the um, recommended guidelines or not. So if any particular system is to be reported, it is to be reported. If TNM is to be reported, it is to be reported. So all those formats should be there with the pathologies, and according to those format, reporting should take place. While pathologies may take so much labor and diligence in writing the reports, but at the same time, if there is some demographic error, it really fails the purpose. So one should be very careful that on the reports, the correct demographics and the correct anatomical details are depicted. Now, once we are done with the reporting, what is to be done with these samples? How they are to be discarded, and if they are to be stored, how they are to be stored. So generally, as 112 recommends that minimum 15 days period is there for samples to be preserved once the reporting has been done. So many of the laboratories where the workload is not much, they prefer keeping the sample for 1 month. In case if you want to re-gross or want to re-examine the specimen, that can be done during that period. Sometimes there is medico-legal cases not generally encountered in the private laboratories, but definitely yes in the government laboratories where the samples is to be kept for much longer time. Now, all samples are to be discarded as per the biomedical waste guidelines. So, biomedical waste guidelines should be taken into account. For example, all anatomical specimens are to be discarded in the yellow container where eventually they are sent for incineration. Now, what do you do with the chemicals? How you are disposing them of? So, formalin can be disposed of with copious amount of water, and while the xylene, etc., can be given to the biomedical waste agencies after proper labeling and packing. So, the safe disposal of the specimen is very important. Unfortunately, there's no much clear-cut guidelines regarding the disposal of the chemicals. So, one should really take some effort
मेट्रो में का इसलिए
to
ठीक है ठीक
do that. Turnaround time is something very important, even for the histopathology, and clinicians do look after that proper turnaround time is maintained and the reports are given within a defined time frame. So it's very important that laboratory defines the turnaround time for histopathology. Now it is equally important that when we are defining the turnaround time, it's better that we define according to the nature of the biopsy or the histopathology specimen. For example, all small biopsies, I think, can be reported in 2 to 3 days, while large specimen can take up to the 5 days. And then if ISC is to be performed, then it might take some longer time as well. So all those, and as a pathologist, we all know that sometimes we do come across the cases where a lot of reading is required, and probably some discussion in the peer group or the discussion among ourselves is required. So turnaround time gets prolonged. Now, in such cases, the proper communication should go to the concerned clinician. And once the pathologist tells them this is the kind of the findings we are coming across, probably would like to take some more sections, probably would like to do some spatial stains or the immunohistochemistry. And this is for the best interest of the patient. And clinicians understand that. So surgeons usually understand that, and so that dialogue channel should always be kept open and should be properly explained to them whenever we find that we are exceeding the defined turnaround time. Now, technologies do help us in reducing our turnaround time, and the one is use of the microwaves. So, in microwaves, for the small biopsies can be used, and some of the laboratories are routinely using that, and by doing that you can again save time. The turnaround time of the frozen section should also not only is to be defined but also to be monitored, and so whenever we get any sample for the frozen section, we must we must assign someone that they record the time, at what time the sample has been received and what time the report has been conveyed to the clinician. Probably one can develop some sort of form, working form, and in which these findings can be written. And I have already told you about the retention period of the specimen. There are other aspects when we talk about the quality in the histopathology laboratories. One of them is being the audits, inventory management, archiving and storage, reporting, quality assurance, participation proficiency testing, peer review, and interlaboratory comparisons. Now, intra-departmental consultation, review of the selected cases by the colleagues. Now, this is also one of the way for the quality control in histopathology laboratory. So, when there are more than one histopathologist who are reporting, they probably can see the cases which have been reported by the other histopathologists. So that kind of interdepartmental consultation acts also as a quality tool. Now, whenever we are doing any frozen, then frozen section findings obviously must be correlated or corroborated with your final report. And in fact, whenever we are releasing the final report of the histopathology, the frozen section report must be included in that permanent report, on permanent section report. That is something must, and must be included. Sometimes we also can, it is, we frequently do cytohisto correlation. So whatever any FNACs or cytology, we report something, would like to see whether it's reporting with the histopathology or not. But not only that, but sometimes vice versa is also important. If we are getting the malignancy in the cytopathology, but on the blocks, or when we are examining the slides, we are seeing that the that malignancy is not there. So there is no harm in going back to the cytopathology section and taking their slides and seeing yourself. And then probably you will take, might would like to take some more sections, or and do some maybe uh, re blocking or the resectioning. All that things can be done. Another way for the quality control in the histopathology is the random case review. Now, blind re-reporting of the random cases. How that can be done? It can be done by the same person. The person who has reported the cases earlier can take out those cases and see himself or herself. Now, it can also be done that the already reported cases can be taken, and those cases are then reviewed by another pathologist. So, in crude terms, we call it when when the same person is examining them, we can say that we are checking for the precision, and when the different person is examining them, we can say that we are checking for the accuracy. Though precision and accuracy terms are more commonly used in quality control of the numerical values. So that is a very a good quality control tool, I would say, in histopathology laboratory. Audit workload labeled to ensure an even distribution of the departmental caseload. This is also something very important, as we know that reporting histopathology definitely eats a lot of our brain, and sometimes we really get tired when there is a whole heap or loads of the trays kept one over the other. Now, it's important that we have a proper load to screen in a day. Now, so it's also important that we distribute histopathology workload among the histopathologists properly, so that no one is overburdened. And sometimes even the expertise can be used among the histopathologists. So someone who is more good, say that in liver biopsies, or so there is no harm in reporting those liver cases by the person who's trained in liver histopathology, and similarly maybe in neuropathology, like that. So the proper distribution of the case overload is something important in histopathology. And of course, we must utilize the recommended reporting guidelines and templates wherever available, and with the audit of compliance. It is a good practice if we see the report retrospectively and see that whether we are following the recommended guidelines or not. And if there is any change in the template, that must be executed and brought to the notice of every histopathologist. There is no harm in going for the external consultations as well. So we can send our slides, which we have reported, to some other laboratories and get them reviewed by the histopathologist there. Sometimes review can also be done by the expert. So if we know that there is one particular person who is more trained in neuropathologies, who's a histopathologist of repute, and if we are coming across such cases, similarly, there's so much. We all know the complexity which lies in the histopathology cases, maybe some lymphoma cases. The person who's trained, who is much more expert in reporting lymphoma cases, such cases can be sent randomly to them to check your performance, how you are reporting. So all those things are very important on the part of the pathologist. And of course, the participation in the continuing medical education is something also very important on the part of the histopathologists, that they keep them abreast of their knowledge and keep participating in the various CME activities. And they should be able to convince the management that this is something very important, and some leave should be granted to them to attend these kinds of CMEs. Uh, Clinico-pathological meetings is something also very important to ensure the diagnostic accuracy and maintain good clinical liaisons. Audit diagnostic changes at these meetings. So path meetings can aim at the case discussion. This frequently happens. There are some tumor boards in many hospitals where they discuss their cases, and there are specific tumor boards pertaining maybe to the gastrointestinal or maybe the gynec or maybe the liver, like that, or maybe the common one. So all those uh, case discussion is a good healthy exercise which can be undertaken, and this is also important when we talk about the quality in the histopathology. And whenever sometimes it so happens that a pathologist is not able to reach at the particular diagnosis, then differential diagnosis are given, or the possibilities are given, and those differential diagnoses can always be discussed not only the clinical path meeting but also with the clinicians. What are the clinical, how they are presenting with, what is their clinical suspicions, and how eventually can be fit into the definite diagnosis. All clinical pathological discrepancy discussion can also takes place in that they were thinking in terms of this, but you have reported this. Could there be something other differential diagnosis which we have missed out, or maybe the clinicians have missed those clinical findings? So all those discussions can take place. This is also an important platform where we can get the feedback from the clinicians regarding our histopathology services, whether they are satisfied with our turnaround time or not, whether they are satisfied with our reporting pattern or the reporting format or not. So all those things can be discussed. And similarly, histopathologists can also put their grievances to them that we are not getting the proper filled up forms, we are not getting that much clinical information. So this is a very important that platform where all those I should say some nuances or some important discussions can take place and eventually can lead to a good quality histopathology laboratory. Proficiency testing, Dr. Shilpa in the morning has talked about that. So we all know what does that proficiency testing mean. So proficiency testing is equally important in histopathology section as well. So every lab which is doing histopathology must participate in the IQA program. As such, it is a requirement as per the ISO 15189 standards. So when we are choosing our IQA program, we should preferably be IQA program should preferably be ISO 17043 accredited, because now the standards of the ISO 15189 2022 clearly says that IQA program should follow ISO 17043 standards. So this is one of the excellent way to know your performance in your peer group. So whatever the blog or slide they have given, what we have reported and what our peer group is reporting. So this will give an insight how we are reporting the cases. So IQA program is not only about the reporting or about to judge the performance of the pathologist, but also of the technicians and the processes in the lab. For example, they probably give you one block also. They will ask you to cut it, stain it, and then send them and send those slides back to them. So by that, they will know how the section cutting is being done, or what thickness generally you are cutting the sections, and how is your staining, what is the quality of the staining, and again they will give you some scoring based on the performance of that. So equa program will highlight your will comment about your performance not only on the reporting aspect but also on your process aspect. So this is something important that one must participate in the equa program. Internal audit is something very important activity for any laboratory. And when we talk about the histopathology, this is also equally applicable to them. So generally, all internal audit programs, it's a good practice that we made some plan in the beginning of the year only, that in this particular month we'll be doing that, and who will be doing that. And it is always a best practice that we should choose a person to do the internal audit who is trained in that subject also, besides being trained on 15189 standards. Because unless he knows the subject, the person will not able to do the justice with the audit. For example, it is a frequent practice which I frequently see in many laboratories audit, is that it has been done, internal audit is done by the person who is just trained on ISO 159 standards, and sometimes and they do not have in-depth knowledge of the subject. Uh, and sometimes they do not have the medical qualifications as well. So probably, so they will just see the processes, your steps, but they will never know what diagnosis you have given, how is the section cutting, what is the quality of the staining, all those things, what are the artifacts, whether they are present or not. So all those aspects can be picked up during the internal audit when it is being done by the person who has an in-depth knowledge about the subject. And of course, whatever the findings we come across during the internal audit must be recorded, and all these findings should be subjected to for review. Whatever the non-conformances which have been raised during the internal audit must be closed within a stipulated time, and again, the record for the same must be maintained. In histopathology laboratory, accommodation in environmental conditions is something very, very important. So when we talk about the quality is not only about giving the good reports or running a lab, but it's also important that we are taking care of all the safety measures, and we are frequently dealing with formalin day in and day out there, and we know how detrimental it can be for the individuals who are working there in the laboratory. So it's very important that there is proper infrastructural conditions which are in place. Grossing area is something where a lot of formalin vapors come. So it must be equipped with formalin hood, and there should be proper, and it should be checked whether it's working fine or not. So now the instruments are available which can do which can measure the formalin and even the xylene content in an environment. And the laboratory can be equipped with those kind of equipment, and then they can do the monitoring themselves. Ideally, frozen section facility should be separate from the area where we are doing the routine histopathology activity. Some, as we know, all that formalin samples, frozen sections samples are received without any fixatives, and sometimes they can be infectious in nature also. So that thing should also be borne in mind. Temperature and humidity conditions should always be monitored, and not only for the persons who are working there, but also sometimes it's very important that particularly for the storage area, we all know that blocks where we are storing, how the temperature condition there. The wax can melt any time if there is a lot of scorching heat is there. So all those things should be kept in mind with respect to the accommodation and environmental conditions in histopathology laboratory. Material safety is something also very, very important in histopathology laboratory. We should know about what is MSDS. It is the Material Safety Data Sheets. Material Safety Data Sheets actually contain the information about those chemicals, about their properties. And so, Saurabh, I will continue with this because I have another lecture on cytopathology. So probably I will adjust my timing in that. So let it be continued. So,
Yes, sir.
so materials. Huh. So
Yes, sir, you
actually,
can
I have an
continue.
because I have another lecture back to back
No problem, sir.
for
You can
again
continue.
cytopathology. So I will continue with that.
Sure, sure, sir.
Okay. So material safety is something also very important in the lab. So material safety data sheet must be kept in the laboratory. So it contains information about all the chemicals, about their properties, what is their flash point, what is their boiling point, and what will happen, whether they are inflammable or they are explosive in nature, or if something happens, if it is on if our body comes in contact with them, then what harm it can cause and what measure should we do. Now all those things, and unless we know about the nature of the chemicals, we really can't deal. So something is very important that whenever we are planning the training, in the histopathology laboratory, training must happen on the safety topics as well, and particularly about the chemical safety. Now, even about the chemical spillage as well. Now, suppose there is a spill of the acid, how we are going to deal with it, or whether there is a spill of the alkali, how we are going to deal with it. Why we are very we know how to deal with the blood spillage, but in histopathology we should be well aware to deal with it. Just to give you an example about the acid. Suppose there is an acid spill, you can utilize it with dilute alkali solution and then get it wiped out. Now, and of course our area should be segregated, mask should be worn also. That is there. And some nowadays, now their material is available which can even quickly absorb those acid materials and alkali materials. Those materials can be purchased for that spillage purpose, where you really you don't have to really neutralize the solution, neutralize the acid or neutralize the alkali by the dilute acid. So that things are not required. You can just put the material on it, it will absorb it, and then you can easily dispose them out. So all those things should be taken care of. And hazardous material storage is again important, as we all know that all big bottles should be stored at the bottom, and should not be kept our eye level, because when we are taking them from the shelf, there could be a chance of an accident, and it could be spill over the body. So those again things should be taken care of, and how we're storing them. Good practice to store them, making a layering of the sand and then keeping it, or keeping some absorbent paper, and then you are keeping those chemicals. All those chemicals must be segregated according to their nature, whether they are inflammable or according to the health hazard. In fact, there is a diamond colored symbol on every bottle, if you see that. And it has in that diamond color, there are four kinds of color coding. Red denotes the inflammability, chemicals, and blue denotes the health hazards, and white talks about some properties. So like that, or any reaction can take place if we mix those reasons with something. So again, those labeling should be understood, which are always there on the chemical bottles. Uh, so staff should be well aware, and all safety devices should be available there, be it your goggles or helmet kind of thing, or the rubber shoes and the gloves. Because when you're making the solution, please ensure that you wear that and then do it. because something chemicals spillage over the body or coming into the physical contact is something of a very serious in nature. Chemical safety is definitely is required by every standard, be it ISO 15189 or be it any NABH standards or be it JCI standards. So all those definitely, and any histopathology laboratory, any auditors takes a good time in auditing the safety aspects. And it is also a good practice if we make some safety adherence kind of checklist and uh, periodically monitor the safety norms in the lab according to that checklist and keep also a record. And it is also a good practice to monitor that safety adherence practice as a quality indicator, and thereby all efforts should be made to improve upon that. So I took some time on this material safety because in histopathology, when we talk about the quality, no quality can happen if we are not able to take care of our staff or the chemical parts in the histopathology laboratory. Inventory management is also something important, where the proper stock registers should be kept for all the materials received in the lab, or it can always be kept in material management system format. Now there is software available for the inventory management, so electronic equivalent is equally acceptable. And whenever we're making any working reagents, it should be properly labeled with the date of preparation and their validity up to. So this is something to be always be labeled, not only labeled, but in fact, it's very good practice to keep a log of that, who has prepared that, what was the date of preparation, and for how long it is valid. Generally, chemicals have a long expiry date, and sometimes they don't even have. So, but when we are making a working solution, maybe it's valid only for a day, or so that should always be mentioned. So when we're talking about the quality in the histopathology laboratory, we must ensure that we are addressing all aspects of the histopathology examination, from pre-analytical to the post-analytical phase. Some of the important aspects pertaining to these phases we have already discussed. In pre-analytical phase in histopathology laboratory, it's important that we have a properly filled up the forms, and tissue must be fixed uh, in neutral formalin, and clinical details are available. We are keeping the proper log of all the alcohols changed. We have made a protocol for the change of chemicals in our tissue processor. We are ensuring that our microtome is working fine to get a desired level of thickness so that the sections are good for the reporting. We must ensure the staining part, and we must run the quality control slides as a routine, particularly for any spatial staining or the immunohistochemistry, and even for the hematoxylin eosin. Infrastructural and environmental condition, as we discussed just now, are very important, must be considered, must be monitored. So I have already talked about the control slides on our day-to-day work, and for our spatial stains and ISC, we must participate in all our training program and CME program. When we ever make the training schedule, please ensure that you must include a topic besides your specific topics. Must include the topics on the quality, must include the topics on the safety aspects as well. Whenever any CME or knowledge enhancing platforms is available, we must use that. We must conduct the internal audit, clinical path meetings, peer review exercise. We have discuss them in detail. We must participate in the EQUA program. We must maintain the proper record of all our whatever we are reporting, because this is something very, very important. And in fact, docs and slides are to be kept for longer duration, maybe 10 years, so that we must ensure that we are ensuring them, ensuring the proper storage for them. And because at any point of time we know that these are to be retrieved, can be retrieved, particularly in the oncology cases, and we must be well aware about the safety practices which are to be practiced in the histopathology lab. So this was the summary about the in histopathology lab. So now uh, this is another important, and I have a next topic to talk about, is that quality in the cytopathology. So I'm continuing with my next presentation here. So I think I can continue without a break, because histocyto something is similar in nature in many aspects. And some of the things which I have deliberated just now are also applicable in cytopathology section as well. So coming specifically to the cytopathology part. So in cytopathology, my presentation is bit smaller than in histopathology, as many of the things are common to both. So, so coming to the quality in histopathology, again, like what we have done in the morning for hematology, or just now for the histopathology, here also we can divide the quality in cytopathology in three important aspects: pre-analytical, analytical, and the post-analytical part. And similarly, it's not only about that, but in cytopathology also, it's very important that we also take care of our reagents part, equipment parts, our reporting format, all quality control exercises, and of course, the proficiency testing. So let's deliberate them so far as the quality in cytopathology goes. Now, as we were talking about in the histopathology, similarly in pre-analytical phase for cytopathology, the sample collection is something very important, particularly with respect to that how the sample is being collected, and whether the sample is properly labeled with patient name ID on the source of the sample. Sample is must be accompanied by the cytopathology sample requisition form, in whatever the name you can give it to them. But even for the cytopathology, it's very important that we develop the requisition form, and so that we can have the proper details for reporting of the cytopathology. So, whenever the patient sample has come for the second time, then the previous cytopathology number should be written on the form for any reference the pathology needs. So it's something, if that information is provided on the form itself by the clinicians or the person who filling up the form, it becomes very handy for the cytopathologist to take the reference. And in fact, it's always a good practice on the part of the cytopathologist to review those earlier slide as well when you are reporting the second time. So relevant clinical history definitely is mandated on the form. This is something very, very important. And in cytopathology, we can't do anything if we don't have any information. So it's very important that we correctly write the site or the site or any history of medication, clinical diagnosis, date and time of collection. Uh, so this is something very, very important. Now, in pre-analytical aspect, something we are routinely performing the FNACs procedure as well. So it's very important that while doing the FNACs or after doing the FNACs, we capture the proper clinical details at the time of FNAC only. So we can ask the patient, do you have any ultrasound finding reports with you or any radiographic finding or imaging findings with you, and you can just write it down on the form itself. And sometimes you can even make a diagram uh, for any swelling, and you can mention draw the diagram on the form itself, so that when you are reporting, you know, you have a clear picture of what the lesion was and how was it looking, where was the exact location. And it's always a good practice to write the size of the swelling if we are doing any FNECs on them on the cytopathology form. Um, that's also something very important. Uh, Sometimes we are reporting lymph node and we see the reactive like picture, then we really want to know the size. If it is less in size, we think that yeah, it's reactive only, but sometimes the node is large and we are getting reactive, then we really look after that. Are we really missing something or not? And if there was the swelling was cystic in nature, we must write how much fluid which we have aspirated, and whether after the aspiration we have uh, uh, again put the needle inside to take some more materials from any solid component or not. So all those things must be clearly mentioned. Now, sometimes radiology department does the FNACs, or they takes the fluid out, and it's good that all those fluids aspirations are being done under the ultrasound or under the mm, radiographic guidance, because they can properly reach the lesion there, even for that is true for the FNEC as well. So it's very important that we have a good rapport with the radiologist, whosoever is doing that interventional kind of procedures, and we also tell them that please fill the form properly. Please let us know the location exactly, how deep it was, how big it was, and so it will all help eventually when we are reporting, because we frequently get after the clinicians and then forget the radiologists as well. So take them also uh, in your team, I would say, and ask for all those findings. A pap smear is always taken by the gynecologist, and we must ensure that on the form, date of LMP is written. If there is any previous abnormal report is there, that must be mentioned, because when we are reporting that, we know that previously it has been reported like this. Now you carefully look for that. Any treatment and or biopsy information should be there. Details of hormone therapy, details of contraception, details of previous surgery. All these things are very important, because uh, this, as we know, if there is some device, copper T or etc. is there, we can get actinomycetes and all. So, similarly, if there's a history of the hormone therapy and in a old women, and we are not getting the atrophic changes, so we know that hormone therapy is being given. That's why the atrophic changes are not present. So all those things definitely, as a pathologist, we know that's helpful in reporting, and my idea here is to include that, because we should emphasize when we talk about the quality in cytopathology as well. Something which is generally missed, something should be emphasized. So your form should have all this column mentioned, and once the columns are there on the cytopathology forms, only then they will get it filled up. Otherwise, not. So it's always a good practice to have your proper cytopathology form and a good rapport with the clinicians, and eventually getting all the information mentioned. So even the collection technique is something very important, and gynecologists how they are collecting the samples ideally from the endocervical canal and cervical transposition zone must be explored, and the sample must be taken from that area as well. This is something important as we all know that CS cervix arises from those transformation zone, and sometimes they will just take the smear from the exocervix part. That is always uh, definitely not a good technique. Nowadays, liquid-based cytology is much in use, in which all the brush and everything is provided. So gynecologists have a that access to the brush and all, so they can take by rotating the brush inside the cervical canal, a good quality smear can be taken. um, so there is always even for the nipple secretion, again how it is to be collected, that must be known to the person uh, who is taking the nipple secretion. And it is a good practice to include both air dried as well as the wet fixed smears. And I would suggest you for uh, if you are into cytopathology, please always make a this habit. Be it any cytosmear, be it FNECs, be it any aspiration or your any fluid cytology, please make two smears. One is air dried and other you make and fix it. Both will act as a complement to each other. Sometimes you have difficulty in interpreting in routine MGG or GIMSA stains smears, and their PAP can really be helped. And similarly, the vice versa. And not only that, and as we know that there are uh, there are both characteristics of these stains are different, and they connote the different interpretation to us in terms of cytopathological screening and uh, in cytoplasm and characterization of the cytoplasm and the nuclear features. So nuclear features, as we all know, are well preserved when we are making the pap smears, where all the metaplastic stains and cytoplasmic characteristics are well discerned in your GIMSA stains. So similarly, the proper instructions should be there if we are going for the sputum cytology, that how it is to be collected after the deep cuff and all that. All fluid sample must be sent immediately to the lab, because the cells in that tend to degenerate fast, particularly true for urine cytopathology or even for CSF, and for that matter for any fluid sample. When taking the buccal smear, please ensure that the mouth has been rinsed well with water, and then you scrap the inner surface of the cheek. So then it should be quickly smeared and fixed. Otherwise, a lot of oral flora and those, then you will have a difficult time. Sometimes, when there is a prolongation in sending the sample to the lab, fixative can be used. 95% ethanol is again a good fixative, even for the cytopathology samples. So, this is the some slide for the good FNAC. Some specifications I've tried to include in this. For that, for small subcutaneous lesion, 2.5 centimeter long, 23G needle can be used. If deeply seated, then long needle can be used. For soft fleshy lesion like lymph node, 22G needle can be used. For serous lesion, again small gauge needle, then that will have the better penetration, can be used. And for vascular lesions like thyroid, small caliber needle should be used, and negative pressure application is not really needed because it is very vascular. We'll put it and the blood will be there. For cystic lesion, again, a large caliber needle can be used because we are not doing harm to any tissues as such, and we're just aspirating the liquid material. And for guided FNAC, because the samples can be deep seated, again, the long needle of the 22G size can be used. So generally 22 to 23G size can be used for doing the FNACs. And sometimes if the sample, if the swelling is very small, and you can do the procedure even with the needle only, provided it's not cystic in nature, and very small lymph nodes and all can be FNAC can be comfortably can be done without any negative pressure. Sometimes people use the kind of the device in which you can well handle, well can get hold, uh, uh, and then and then can use can that device. Otherwise, any syringe and needle will do. Preferably the 10 ml syringe is better, because then you can give a good pressure rather than using 2 or 5 ml syringes. So, like in history, we have talked about the sample receiving. Now, similarly, here also we should know that whether the sample is acceptable or not, and what should be the our acceptance and rejection criteria, that should be well known. So, some of the important criteria for the rejection could be unlabeled sample or the mislabeled, or sometimes they're empty vial or irreparable broken slides. So wherever the chances are there, we try to preserve, we try to repair those slides and then see it. But if it is broken beyond that reparable state, then obviously it will come into the rejection criteria. In as we were talking about the histopathology samples, here also the processing of the fluid sample should be important, that we take properly take care of all the fluid samples, particularly when we are processing them. So sample received during the daytime can be submitted fresh and without fixation, no problem. But sometimes the sample come in the night, and then you're going to process them in the next day morning. So again, although degeneration, to avoid that degeneration, you can fix them with equal volume of the 50% ethanol and refrigerate them. So it's very important that your cytopathology lab have a refrigerator. Specimens sometimes with the high protein contents can be preserved for 12 hours if they're refrigerated. And a specimen like CSF and urine should be processed immediately. If submitted during night time, then cytospin or centrifuge. Smears to be made both airtight and wet bags. So for particularly for the urine and CSF samples, try to make the slides as soon as possible. Sometimes there are a lot of blood in the samples. Then you would like to add, you can add 1 ml of glacial acetic acid to the 50 ml of samples, or in that ratio, so that the hemolysis part is taken care of. So, erythrocyte hemolysis after slide preparation, if on the slide, if you are seeing that a lot of blood is there, what you are going to do now, what you can do is that after 5 minutes of fixation, 95% alcohol, smears are kept in the copeland jar containing urea solution for 20 to 30 seconds, and then transferred back to ethanol fixative and stained routinely. This is one of the practice which can be done after you know that a lot of blood is there in the slide. Staining technique, as we all know that we are using the papinoculose stain for all exfoliative cytology. FNAC slide should always be stained with MGG along with PAP, or some people have a comfortable in HNE. But PAP or along with MGG or HNE can be, I think, is a good match, something one should do. But try to include always two stains. That is always a good practice in cytopathology. Make sure that you have a SOP for all the stains you need in your day-to-day practice. Take particular precaution when with pH of the buffer distilled water, which is 6.8. Do check the pH of the diluting buffer distilled water. Special precautions like slides should not be permitted in alcohol solution for longer time, particularly after OG solution and EA dye, as the stains have penetrated the cells will be washed out. So if we put them in alcohol for long solution, your staining will not be proper. So there will be very less stained slides you will be looking at. Now, when the slides are transferred from water to the hematoxylin, the grassy droplets of the water on the slide must have disappeared. Now, if not, hematoxylin will not penetrate the nucleus and the cell again may appear hazy. So, all those things during the processing, we should be well aware of when we are reporting the case. So, gynecological and non-gynecological stain should be stained separately, obviously, and check the pH of the tap water and ammonia solution following hematoxylin staining to ensure that it is sufficiently alkaline. So, all those staining techniques should have a proper quality control mechanism. Again, what you're going to do with the samples which you have already processed and reported, you must again comply with biomedical waste guidelines. Store the sample for at least 24 hours at 2 to 8 degrees Celsius in case if you want to reprocess. All cytopathology slides are to be preserved for the 5 years. Keep them in a slide cabinet in proper chronological order so that the retrieval is possible if you want to review any slide. Uh, So, all those slides are because of being made of the glass, and if you want to discard them, make sure that you're discarding them in puncture-proof blue colored container. Uh, so, otherwise, the rest of the things you know how to discard them. So, regarding the reagent and equipment part, whenever any new lot of reagents or stain is opened, the first stain, the slides checking for the performance, the stain and reagent must be done. Any reserved slides can be stained for checking. So, it's very important that you do that kind of new lot verification, which is something something important and must maintain a log of all the reagent change. As you are keeping the log, you are making the protocol for the reagent change or the alcohol change or the solutions change. Similarly, it will again depend upon your
Sunday
workload.
also.
So it will depend on the workload also. Equipment like cytospin or the centrifuge must be calibrated by an accredited laboratory for the frequency which is used by the lab. So whatever the frequency, make sure that you are using those much RPM calibrated and your certificate mentions about those RPMs. Maintenance of the equipment to be undertaken as by the manufacturer. So whatever the conditions, whatever the periodic maintenance required, that must be done. In post-analytical aspect of cytopathology, reporting is something very important and is to be done according to the latest prevailing guidelines and the nomenclature. Comment is to be made about the adequacy of the material. Some of the recommended reporting nomenclature I have just included that you must report according to this. For example, the Bethesda classification for reporting on gynecological pap smears. Again, Bethesda classification is also used for reporting the thyroids. Paris classification is something for the urine, and Milan system for the salivary gland cytopathology. So all those a proper uh, standardization or the classification for the reporting has been recommended. All those must be used. Otherwise, your report won't look good. So, CAT also must be defined for all cytopathology reports. Usually, 1 day is a good time, unless uh, something is very critical in nature, something very important or requested by the clinician. Now, here I have not included about the rapid on-site examination. So again, turnaround time should also be monitored when we are doing any rapid staining. Now, it is frequently requested by the clinicians, particularly for your endoscopic procedures like TBNA or endoscopic ultrasound guided lesions from the intestine or stomach, etc. So for all those, it's better to make some form, a report, at what time you received the sample and what time you have conveyed them the results. And whatever the reports for the on-sites, whatever the results for the on-site examination you are telling to the clinician must be recorded, and and to whom you have told them must also be recorded. So it's better to make some form for the rapid on-site examinations, and you keep a proper record of them, so that when you are reporting later on, so that there should not be any discrepancy in that, or the clinician should not say that you have communicated me this, now you are writing this. You should also know if something discrepant happens, what is the reason behind that. So all those things must be recorded and told. Any explanatory comments are to be given in any unsatisfactory or equivocal reports, so that the report is well understood to the clinician. And sometimes we write that these atypical cells are present. What further can be done? Is biopsy required, or it is so? Whatever information can give must be given. Now, positive for malignant cells, there are most of the terms used. I see the reports when they come for review to me, and but if you are seeing the clear-cut differentiation of the squamous cell, please write down squamous cell carcinoma. It will help the clinician. So wherever we can help them, we must help them. So positive for malignant cells really won't help the clinician to start the treatment. Now, frequently, if we are getting that this is an adenocarcinoma, why not report that? It will help the clinicians. So wherever we can give the information, it must be given. Sometimes we get the information which clinicians are not really expecting. Just a few days back, we got the pus sample, and of course, all pus samples, whatever we do AFB staining on that by default. So while looking for the AFB, we found the hooklets there. So it was a case of hydrated cyst. And the clinicians, of course, they were thinking in terms of tuberculosis. So, so we have provided that information to them, and then and of course they started the treatment accordingly. So our small these efforts go a long way for the clinician. That should always be borne in the mind. If you're reporting everything like the positive advice, biopsy advice, the clinician won't have faith, and that really won't be a good quality report. So all those wherever, of course, required must be done, and whatever the classifications internationally have been recommended, that must be followed. So that reporting part is something very important and must be there. Now, quality control part. Now, if gynecological screening slides seen by the trained cytotechnologists, then 10% of all negative smear must be reviewed by the pathologist or cytopathologist. Now, this is a statement I have taken from the specific criteria by NABL and all. So, even some of the books, they have recommended that, because in many countries, cytotechnologists are reporting pap smears. So they say that 10% of those must be again reviewed by the pathologist. But in our country, I, I I don't know where cytotechnologists are really reporting the pap smears as well. Now, another important quality control technique is that we can rescreening of the previously reported slides on receiving the fresh smears from the same patient during the follow-up, and review report of the same is to be mentioned on the current report. So even if the previous report, we not only we have to see that, but you also should mention on your report that previous slide dated so and so, bearing number so and so, also reviewed and showed the same findings, or the findings and that there is no change in the earlier reported diagnosis. This is something again have a very good meaning. Records of checking the quality of the staining, which is to be done every day and whenever any new lot of stain is opened. As always, a good practice that you maintain some kind of register, one of the slide, stained in the morning is shown to the doctor, and then pathologists or cytopathologists then put their comment about the staining part, and then rest of the slides can be stained. As important, we were talking about the proper distribution of the histopathology workload. The same is true for the cytopathology as well. Avoid overscreening of the slides by the cytopathologists, because if the overscreening is done, some findings might be missed. And how quickly we are moving our fingers on in the microscope, that also matters. And suddenly, if there are a lot of work, we start moving our fingers so fast that we tend to miss some important findings. And at one place, it was mentioned that should not be more than 100 slides in 8-hour duty. Uh, so it's more, I think, more of the pathologist himself or herself would know how much slice comfortable with and can be reported. Particularly to the, it's very important in a large size laboratory where a lot of works pouring in for cytopathologists. So something control should be exercised for to avoid the over screening. It's always important that any cytopathology case, if it is followed with biopsy or histopathology, and we must do that correlation. Cytohistocorrelation is one of the quality control tool, must be exercised. Any lab practicing histopathology and cytopathology. If any discrepancy seen, then slide must be reviewed for all our learning purpose, and record should be kept that this was the cyto finding, this was the histo finding, and when you reviewed, what did you find and what actions you have taken. Now, as we are talking about the histopathology, same is true for the same is true for the cytopathology as well. Regarding the peer review, we can make some program to get slide reviewed by our peer. And then, of course, the cases must include both malignant as well as the non-malignant. The both are very important. In non-malignant, we might have missed the malignancy, in malignant, and the vice versa. So, ideally, both cases should be included when we are talking about the peer group review. And some of the quality indicators which have been using, and one must do that when you are reporting the pap smears in your lab. Number of the atypical squamous cells, what is their percentage? And percentage of the atypical squamous of undetermined significance to the total number of atypical squamous cells, number of cells, squamous intraepithelial lesion, and ask cell ratio. This must be reported and acts as a quality indicator. Proficiency testing is something again important. The laboratory must perform in the PT program. And if we nowadays, when they send you the set of slides and you report them, and uh, and immediately they will send you the answer key. So the slides are with you only. And whenever you're finding that you have made something wrong, you can always review the slide yourself before sending back to the PT providers. So always see the slide back. Where have you missed out? What mistake you have done? This is for our own learning. And of course, when the final result of the PT program will come, we'll know our performance versus the performance among the peer group. So what are the consensus has given and what you have given. Okay. And so besides that, you can, in between, you can also participate in any inter-laboratory comparison program. And again, you can maintain the record for the same. So usually when you are doing that, even the PT program, PT provider should provide you the slides of a bit challenging in nature if they really want to judge your performance. And similarly, interlaboratory comparison can be done on the slides which are a bit complex, borderline, or challenging, so that let's understand how the peer group is talking about those. All those easy cases, I'm sure, will be like that, only fibroadenoma, or IDC. So besides that, you should also include those kind of cases as well. Staff, of course, should be trained on the various SOPs, techniques, and training schedule must be made. Pathologists should enhance their knowledge. So, to summarize, quality in the cytopathology, that proper aspect of the collection is taken care of by ensuring that we are correctly getting the cytopathology specimen. SOP should be made for all screening and processing. Equipments are to be calibrated. Staff should be trained. Cytopathology form must accompany and to be filled up with information required. If you are filling it yourself after doing a procedure, make sure that you are doing that. Reporting is to be done according to the latest system for reporting. Quality indicators for the PAP screening must be evaluated annually. Quality control program is to be designed. Lab must participate in proficiency testing or inter-laboratory comparison program. So with this, I would like to end my presentation. So thank you very much for your patient hearing. So is there any question? I can take it. Otherwise, we'll close the session. So if there's none, I think I can close my session now. Saurav, are you there? Yeah, someone raised hands. Let me see. Chat box. Okay. There is one question, cytoslide preservation for 5 years or 10 years. It is for 5 years as per 112 guidelines. So, thank you very much. Saurabh, are you there? Can I leave the session? Cyto, there's one more. Acha, FNEC TAT. Usually 24 hours is a good time for the FNEC TAT. You have to define yourself. Cytopathology samples storage time. Usually 24 hours is a good time. However, the slides can be kept for much longer time. Unstained slides can be kept for much longer times, or you can fix them and also keep it. Um, Otherwise, all fluid samples are there. You can just keep them for 24 hours. Uh, Sometimes fixed smears are washed or what needs to be done. So that's why I am always saying that always make two slides. For example, you always go for dried smear as well as a wet smear. If something happens in the wet smears, again you have something to fall back upon. So it's always make it.
Now, and that was a very good deliberation from Sir Dr. Dilip, and he's a guide also. So he has delivered many things which and made my task very easy today after giving so much of insight on the quality control in laboratory and as such the whole thing. I will be deliberating mainly. I'm a principal consultant microbiologist, so I will be deliberating mainly dealing with microbiology. What are the challenges we are facing and how we go about it for the microbiology cultures. So yeah, I think it's a little bit slow. So the QC program, we all know what is the QC program. The QC program is mainly looked by the laboratory director and primarily responsible for the quality control and quality programs. However, all the laboratory must actively participate for the quality controls and quality assessments program. What it does for any laboratory and microbiology laboratory as well is the positive patient outcome in the microbiology laboratory. and it causes the reduced length of stay, reduced cost of stay, and reduced turnaround time for the diagnosis of infection. And it also helps in the changing of the proper antimicrobial therapy. We all know the talk of the town. In if we talk about microbiology, only one thing comes in our mind, and that is antimicrobial stewardship program and antimicrobial therapy. So this is required to use for non-judicious use of antibiotics, to stop overuse of antibiotics. And this is what is termed in giving us the customer satisfaction. Satisfaction simply means my physicians are happy and my patients are also happy if they get a right kind of antibiotics in there. So the basic elements in microbiology as such is the specimen collection. The specimen collection is the most important part we will be dealing. What are the important challenges we come because of the training part of so ever. Then other part is standard operating procedures. We should have laid down, as Sir told, the standard operating procedures for all our microbiology is whether it is gram staining or AFP staining, or even the maintenance of the microscopes, or we have the quality controls for antimicrobial white sensitive susceptibility testing, or we are having media procedures. So everything should be written down in a manner that is that can be taken care of. Then the personnel should be trained properly, and there should always be a proficiency testing of each and everything, whether antimicrobial this, either you are doing by this diffusion method or you are doing it by Vacek method. Then all this quality control procedures, and the most important part whenever we go for assessment is how we are maintaining our QC stocks. The quality control stocks needs to be had in a proper manner. So we all know that it cannot go beyond certain passages, that is 5 passage to 7 passages. That is what allowed by CDC guidelines and also by our guidelines from NABL 112 also. I don't know if it mentions, but it should be there that it should not keep on passing for innumerable times. And it should always be that antimicrobial susceptibility falls in a range of either sensitive, intermediate, or resistant. It should be very, very clear to us. And then the patient's reports. Since the quality control, the microbiology reports are usually not just 1 or 2 page when we are giving a positive culture. Usually it can range from 2 page to 3 page at least, and it has got all the details. So everything must be written down on the patient reports along with the interpretation part. So this will be something we will be dealing as basic elements of quality control procedures in us. So first is specimen collection and transport. The laboratory is responsible for providing instructions for proper collection and transport of media. I mean, this cannot be emphasized more. So suppose I give an example of urine collection. Urine culture and sensitivity needs to be performed. So whenever the patient comes in OPD, we need to tell that a midstream urine needs to be collected for a proper collection for transfer for the culture and sensitivity. Otherwise, it will give rise to more of the contamination if the first part is not taken, or the genital hygiene is not maintained. More of the normal flora comes in these cultures, and we are unable to interpret those transfers. So these instructions should be available to the clinical staff for use when specimen is collected. So we cannot emphasize more on the specimen collection. And when it is there, so for urine culture, yes, it should be all displayed. Then the other part is your sputum collection part. Now, sputum collection, it needs to be done in an open space. Mostly what happens in sample collection room, they are small and they may not have a proper ventilation. So always ask the patient either to have a first morning sample which he can collect in his home and bring as soon as possible, or if the patient has come to your OPD, a sterile container must be with him. He must be guided to another secure place where he can cough out a deep cough needs to be collected. And whenever we are having this collection part, we should always, when we are receiving these samples, then we should show that the salivary samples are not taken, and only a deep-throated collection needs to be taken. And if it is there, we can always rejection. So the specimen needs to be have a proper instructions available to the clinical staff whenever the specimens are collected. And these, whatever way you are collecting your samples, they have a written collection protocols which should be displayed in your sample collection room. It should be displayed in your IPD spaces, and it should be readily available for any reference. So, text selection criteria needs to be there, patient selection criteria need to be there, timing of the safer for sputum AFP, whether it's a morning sample or it's a spot sample needs to be taken, because in both the times the amount of AFP seeding, say if we are taking it for tuberculosis, so if it is not a first morning sample, at least one morning sample according to WHO guidelines, it needs to be taken. So the timing of specimen is very important. Same way, if a urine sample or urine culture is given, it's a first morning sample for AFP, or it is again for a 24 hours collection. So it needs to be there. And the other instruction which should always be there is that before any antibiotics are given these collections, because when the cultures are taken and the patient has taken antibiotics, the bacteria gets inhibited and we don't see any growth. So always take a history whether the patient is having, even if it OBD, if he's taking any antibiotics or not. And if coming from IPD, it should always be trained to our doctors and nursing. Whenever they are giving, they should always mention the history of antibiotics. Then optimal sample specimen, that's the most important thing. Then specimen collection site. So in our hospitals, we have a tendency to take a paired culture, blood cultures, and it is one, if it is an ICU, then it is coming from central line, or it is coming from the hand, or it's coming from the one of the arms. It needs to be mentioned, because when we track our as a microbiologist, we are also tracking our infection control, nosocomial infections. We need to have time to positivity. That means which culture came positive from which line, and if it is suppose it's coming from line positive and our peripheral hand is not positive, or it is negative, or it is sterile, so we track it in CLEPSI, not CRBSI. But if both the specimens coming from central line as well as from our arm, then it goes into another criteria. So criteria changes when the collection site is not there. Suppose a patient is coming from pus. Pus is coming from where, that is very important. Say it's a contaminated wound, it is coming. Say a patient underwent an open GIC surgery, and and we are isolating E. coli. Then it means that we do not to put the sensitivity. We just have to pick up phone and tell our doctors that the isolated organism is E. coli, and this may be a normal flora. So don't give your antibiotics. That is very important. And approves specimen collection method again becomes very important. And the other important thing is to have specimen transport media. So all this, in which transport media? Suppose a patient takes a container, a sterile container, because he's not able to give you a stool culture or stool. So what you do is you give a sterile container. You always have a transport media so that the normal flora does not get multiplied, or a vaginal swab or a cervical swab that needs to be collected. It has to be on charcoal maintained. Specimen needs to be transferred. So specimen transport media are important, and all these protocols should be nicely displayed in sample collection room or an IPD collection room, or a clear-cut communication between the patient and the person who is collecting the samples must be trained for this. Then another criteria for quality control, for maintenance in quality control in microbiology, is specimen transport time and temperature. Any specimen cannot be held beyond 24 hours if it is not in 4 degrees, but some specimens cannot be stored for anyhow. So availability of test on site and with hours of test performed, these are something which we need to always say, that suppose a urine culture, if kept in an OPD for more than say an hour, more of normal flora will be there. So it should be transported cool temperature or cool pack, so that it goes to a processing lab. We all know there are a lot of collections happening outside the hospital surroundings. So the appropriate temperature needs to be taken into account. School packs must be there in the transport bag. So, and temperature monitoring is important in that case, so that we can have a good result, not just normal flora or contaminants comes to us, but a right kind of flora which the patient is having and which we are expecting for the giving the ultimate aim is to give the right antibiotic. It needs to be taken out. Then what is the turnaround time? So some hospitals or some microbiology labs, they will give turnaround time urine for 24 hours. Some can give urine for 48 hours. It all depends what kind of patients you are catering to. So if suppose you have a transplant unit, so in that case you will take a urine culture to 48 hours, but that needs to be mentioned in your SOPs, whatever the temperature or whatever the turnaround time of yours is. And what is the result reporting procedures that needs to be defined? What is the interpretation? So if you're giving just the antibiotic without mentioning it, it is sensitive, intermediate, resistant, it is of no use. So always a reporting procedures must be taken. Or suppose you have isolated some organism which is resistant and which needs a synergistic testing, that needs to be mentioned. That for we know, just for example, for microbiologists, if they are in the audience, that salmonella typhi, fluoroquinolones, they need to be tested in our prototype drugs so that we can be sure that antibiotic is working. Say clindamycin, if we are giving, we are also testing it, synergy testing for. So some organisms will respond to synergy testing, some will not. That needs to be mentioned in reporting procedures. Or say Enterobacter C, which is ESBL. So you need to mention this is an ESBL. So this is the importance when we will have any reporting procedures needs to be taken. So as I said, information need to be filled. The patient needs to be there. Hospital or laboratory number should be there. Ordering physician is very important, especially if you come across a test, say triple H, and which contains HIV, HPV, HCV. So if you don't have an ordering physicians, you also need consent in some of the cases. So that consent needs to be filled. And the ordering physician, suppose a patient came positive, you cannot release the result over online because online reporting is so common. You have to communicate to your the ordering physician so that he can counsel the patients or patient's relative. So that is very important. Patient is receiving any antimicrobial therapy, that is the utmost, as I said. And any syndromic, say a patient is having UTI with multiple stones, sometimes we do get double organisms. So we can complicate, which is very common if the patient having renal stones and there the UTI may be due to multiple organisms. So in that case, if it is a complicated UTI, so we should know that history, and every lab should have a microbiological requisition form which has these, at least these important. There are many other things which you can give, but these are some of the most important things which needs to be written over the information or the requisition forms. Then the another one is, as I said, the criteria for unacceptable samples. That is true for anything, not just for microbiology, but also for other pathological specimen. We say unlabeled and mislabeled specimen. This is a complete no-no. We can never have it. Then the second is use of improper transport media. If the transport, say, a dry substance, if a patient dry swab, say throat swab, which is almost dry, it needs to be transported, or it should be at least wet when it is being done, processed in microbiology lab, then it's a rejected sample. You can always give a comment that it is a dry soap, we need another sample or a repeat sample. Then sometimes we see excessive transport time. So for urine cultures, especially not for sputum, but urine, I must say that it must be transported in a manner in which the normal flora does not overgrow, like Staph aureus, not Staph aureus, Coagulus staph, that needs to not grow. So it should be given as soon as possible, at least 1 hour or within 2 hours if it is in a temperature controlled environment. Then improper collection site, it needs to be done. Specimen leakage that we come across many a times. The transport container coming from our IPD samples, they are leaking. They are a total no, unacceptable specimens time. Then sometimes sirars we get lipemic or contaminated. That needs to be a rejected sample. So our criteria of rejected samples should also be displayed, trained, or displayed in your OPD and IPD areas, as well as in your manuals if you are having. They should be displayed. Then coming to the QC program, the standard operating procedure manuals that are a must for any ready reference if you need. And these should have the test performance, that what is the performance criteria, the tolerance limit, or we say the reference ranges. If reagent preparation, say if you are having say AFP or a modified AFP. So what are the reagents, how you are preparing that reagent, that needs to be defined again in your procedure manual. And required quality control, what is the reference quality control for that? And the results reported, are you referring to CLSI guidelines or UCAS guidelines? That needs to be there, and the references. So all these needs to be very, as you see in pathology, we also do it in for microbiology. The standard operating procedure manual should be including all this. And this should be written in a CLSI format and must be always reviewed and signed annually by the microbiology director or your laboratory director or anybody, a quality manager, whoever is responsible for putting up these standard procedure manuals. The SOPs should also be worked with this. So sometimes what happens, people do, they do write procedure manuals and they keep it in their drawers, and when the audit is happening, that SOP comes out with a surprise. That should never happen. It should always be available in the working area. And a definite laboratory reference should be there. And any questions related to these individuals that should also be identified and addressed. Any obsolete procedure should be dated and it should be removed from SOPMs, and it can be reviewed for at least 2 years. So that ready reference should, what happens if anything keeps changing, though it changes very less in microbiology, but if it keeps changing, so that needs to be done, and it should be an obsolete file and retained for 2 years. Then personal, the importance of personal should always be there. We all know laboratory director or somebody who is a responsible person, who is a qualified person. So qualification depends what are your scopes of work in your laboratory, not just scope for NABL or other accreditation bodies, but scope of your work so that you can keep. So sometimes what happens, just serologies are there. So we don't need to have a full microbiologist, but a pathologist who is trained in microbiology also can do work. So that needs to be defined. But the document competency and trainings, it needs to be done twice a year or once a year, whatever the protocol must be there. You should have a continuous education program should be provided. So there's a lot of accreditation rate we have seen these days in laboratory as well as in other areas of healthcare. So continuous education program must be there. And with the advent, with coming of COVID, so many advances have come in microbiology. We also see in flow, we also see in molecular genetics. So continuous education program must be there for your enhancement as well as for your technical staff enhancement. And for all this, and documentation should be provided in their personal life. So whatever is important for pathology is also important as a quality control in microbiology also. Then proficiency testing, where every lab should participate for proficiency testing. So there are, for microbiology, we all know there is an ECPOS program, which is run from CMC Vellore and also run by Gangaram. In both the cases, they give our ECPOS. There's a PT cycle, which is there for quarterly basis, and where the specimen comes for stainings, whatever the gram stain, AFP stain, then serology, and also your antimicrobial for culture sensitivity. It may go beyond this area, say molecular or fungal or tubercular, but whatever it is, a proficiency testing program must be run by every lab to maintain the quality control in microbiology. And whenever the proficiency testing, it is always said that any samples coming for this program should be run like a normal sample. So you give, maybe you are giving it to a highest qualified technical staff, but I would suggest give it to the lowest quality, the newly trained staff, so that we also see the trainings needs to be done. So that we are doing it in the day-to-day basis. Then laboratory procedures and equipments are personal or all checked process in the proficiency testing. That simply means that um, the reagents, so say a gram stain or AFP stain, whatever the equipments you are using, say you are using an automation method or you're taking it any manual methods that needs to be defined, equipments for say your laminar flow, equipment for your safety cabinets or equipments or Vitek, everything needs to be checked in the processes. So idea behind this proficiency testing is that the whole cycle from the procedure, whatever you are doing, the reagents, whatever the equipments you are using, as well as the training. So from end to end through this proficiency testing, we get the process which is validated or verified by the external agency. That is what we call as external quality program. So this provides laboratory management with the insight what is going wrong or what is going right, both ways, not just right and wrong, but what is going right also. It's also an eye opener sometimes that we can improve upon this. And this should improve upon the local and national standards, whatever the guidelines say. The level of unsuspected areas of difficulty needs to be there. Then provided educational stimulus for improvements also definitely. And checks a control internal IQC, internal quality procedures are also checked if we are running an external quality program control. And it also demonstrates our achievement also to which can be done for the quality. Then the performance checks instruments, they are important. Whatever you have, you should have an equipment log, should contain following information, instrument name, serial number, date, also should be there. The procedure, what are doing, what is the periodicity? It's a daily maintenance, weekly and monthly maintenance, or a routine check. So that should needs to be defined in your quality control program. Then what is the acceptance performance ranges? That also needs to be defined. Whether the instrument, if the instrument goes in any failure, what you are dating, what are the specific details taken, what you able to release your results or you're not able to receive your results, or you had a backup instrument in that case. At what time you have given the request to your the team that the equipment breakdown is there, any preventive maintenance, it was there, not done by manufacturer's recommendation. So these are some of the things which need to see as now the microbiology has gone beyond the manual methods to the automation method. So more than Vitek and BD and many instruments have come which people are using. So we need to have this. Then if you're talking about our serological methods, the algegraphs and other quality controls needs to be taken in that case. Then coming to the maintenance record, it must be retained in the laboratory for the life of the instrument. Still the instrument is there, so it is there. The specific guidelines regarding periodicity of testing of autoclave. So daily maintenance for autoclave is very important. We're talking about microbiology. Then quality controls which are run on IQ, OQ, that is when the autoclave comes. What you have done? So did you check your load? Where was the load? That needs to be done. And on biological indicators needs to be done according to your load, maybe a monthly or a quarterly basis, monthly or a 15-day cycle, or maybe it could be a every weekly cycle. Then biological safety cabinet, is it working fine? Now this is very important, which is mostly neglected part we see in microbiology laboratories, that because people don't care about personnel. So that is what is occupational health hazard, because all the time we are dealing with the infectious organisms. So biological safety cabinet, they should be working fine. The exhaust, the UV filters or HEPA filters, whatever you are using, and the hygrometer needs to be checked how much of air it is being exhaled and how much inhalation of that same air we are doing. Is it purified or not? That needs to be checked according to the maintenance records must be there. Then centrifuge, again, incubators, microscopes, refrigerators, freezers, water bath, heat blocks, and other microbiology laboratory can have and they can be referred to any reference standard reference books for their proper functioning. Now, many people ask about the quality control of culture media. We have to make the media, or we can take a prepared media? Now, in both the cases, the idea behind is to have a sterile culture. or sterile plates whenever we are doing it. If they are contaminated, we won't be able to do any thing for it. So the commercially prepared culture media, the CLSI subcommittee on media control collected their data over several years, and they have defined the QC failures. So based on this committee, we can have our quality process in place, whether it is a prepared media or a media which you have prepared. The laboratory, if it is a prepared media coming from anywhere else, we should always check for the maintenance of the temperature cycle. And whenever it is coming, is it a cracked media? It is having bubbles or clarity is not there. Clarity is there. If you are getting a blood agar media, whether the hemolysis is coming, all kind of hemolysis are coming or not, we need to check it with our quality controls also. Unequal filling, visible contamination. So we make sure if it is a prepared culture media, these things are not there. So that's the criteria for rejection of our commercial media. For sterility checking, always a representative sample. We have seen a lot of people what do, whatever the media is coming, they will put in the incubator and see. But it is not required. Only 5% of any lot is what is required, which can be tested for the sterility. And it can be checked in batches of, the whole batch needs to be checked. And then the maintenance part comes on us, whether how we can take the sterility. So sterility is routinely checked by incubating the media for 48 hours at a room temperature, which will be used. So people ask me 24 to 48 hours. Usually we do it for 48 hours. Then for performance testing, what we are doing is we use a medium dose, which is quality control in-house media. It can be a complex, but several basic rules must be followed. That is, all media must be tested before use. That is most important. Are you checking it out? That is, and we each media. So every media which we are putting up in microbiology has a standard reference range for checking media. So if you're using a blood agar, it should have a cheap blood and it should show alpha beta hemolysis. So you have standard strain of Staph aureus, which needs to be done. So if you're getting a McConkey agar, lactose fermenting or non-lactose fermenting, we need to see both negative and positive. So these are the performance testing which we need to do every time the media is prepared. So media need to be tested for sterility and pH. Organism should be selected. Primary plating media should be done in dilute suspension. Sometimes QP testing is also done. And expiration date. Sometimes I've seen that you don't mention your expiry date on the media plates. That is the most important thing. Then coming to stains and reagents parts, this needs to be defined. Containers of stains and reagents, it should be labeled as contents, their concentration, their storage requirement according to the manufacturer's guidelines. And a negative positive controls needs to be there. For anti-serums, the lot number, dates received, condition, what is received, and expiration date is also very important. And all shipments, whether it was a cycle was maintained or not, any previous, and this needs to be done with lot verification. So new lots, whatever you're getting, it should always be tested with the previous lots or media. Now coming to antimicrobial susceptibility testing, for these control organisms must be tested with each lot or a batch of antimicrobials or media daily, sometimes thereafter, but we are doing it according to the load weekly. So daily testing of our stains, daily testing of our media, and daily testing and weekly testing for our antimicrobial susceptibility testing. So that is required and that is suggested by CLSI guidelines. So single isolates of pure cultures should only be used. Sometimes we do get contaminated cultures. We should not be using a single pure colony is usually used for final performance of antimicrobial susceptibility testing, no mixed susceptibilities. And these criteria, they need to determine the presence of endpoint or zone size, which is against given the CLSI guidelines criteria, which needs to be validated. Then the inoculum, which is used for antimicrobial susceptibility, is also designed 0.5 McFarlane, or there are certain dilutions which need to be done. Maybe this, because this is very important, the inoculum size. If you make a dense one, the zone size becomes less, and then your quality control goal for a toss. So that is very important, whatever the inoculum size you are using. For the reagents and equipment used in the test, the goal of quality program is to monitor the precision, or accuracy of susceptibility test procedures. Multiple parameters can be monitored by following quality control recommendations such as reagents and equipments which are used in tests, and the person who is using these tests are also important, which is resulting. Now, sometimes what we see here, out of control results, it could be due to random error, it could be there, or a corrective inoculum is not there, or a wrong procedure used, or a wrong card if you're using automation system, a wrong card you have applied, or the disk criteria, whichever you are using, you are not having the appropriate interpretative criteria, sometimes we see, then these results, they are not carried. So, coming to the reference range, which I have been checking, so reference trains for quality controls, which must be used, at least this much must be used in all quality labs. That is Enterococcus faecalis, E. coli, Staphylococcus aureus, Strep pneumoniae, sorry, Pseudomonas aeruginosa, Klebsiella pneumoniae, and Haemophilus influenza or ATCC strain, they are present, and that needs to be there. Then the maintenance of QC, because of whatever work you are doing, if you are not documenting, again, this goes for a task, because whatever you are doing needs to be documented in appropriate record form. All QC results must be recorded in appropriate QC forms you can make or according to, and if any deviations you obtain in this, corrective action should also be noted in these forms. If temperature is adjusted, a biochemical goes out, a new reading with again should be tested, retested, that is what is required. If again retesting fails, then you should look for the quality strain which you are using, whether it is an expired one or a more passages are happening. So, and in many laboratories, supervisors reviews and initials all forms weekly, but at least the person, the microbiologist who is working in that laboratory should also at least weekly basis should check their QC record. And the supervisors and with the microbiologists in tandem, they can note their results. And this needs to be maintained for at least 1.5 years or 2 years, except in which the life of the instruments must be taken. Then patient reports, that is what our goal is. As I said, laboratory must have established a system for supervisory or laboratory reports only microbiologists can approve after proper reviewing and checking of the specimens, and conclusion or any clerical errors in noting down the results has been given away. Then it should only be given by who has an appropriate authoritative signatory in your lab, who has to sign the reports, can only sign the reports, not the supervisors or not anybody else. Properly qualified person should be approving the result. That is more important whenever you are doing. Then the other part which we often is in microbiology, the panic values. Panic values means an Albert staining, AFP, the blood culture, say it comes positive, then it needs to be done. Any gram stain of AFP, these are certain examples, but you can always, this needs to be notified and this can be built upon, and this needs to be done. So all patient records should also be maintained. So this is all about, I don't know what, where went my thank you slide. This was my live slide about the panic code. So the house is not open for any questions. If are there, I hope I have covered most of the quality controls in microbiology which is required pertaining to aerobic cultures and more normal culture. I'm not talking about much on AFP cultures or fungal cultures or molecular genetics, but mainly on that same basis, we can have the other things also. The basics remain the same, that your stain, reagents, media, your reference material, your manufacturing instructions, the documentation and retention of records for ready references, the interpretation, the reports remain same, be it aerobic, be it fungal, be it tubercular, be it for molecular genetics. So thank you so much. I have few minutes left for my question. If any questions, please do come forward for that. So I kept 5 minutes for actually my question answers. So either it was very precise and everything got clear, or it didn't clear. It went both. So can I have questions? Few of the questions for us. So if there are no questions, I think Saurabh, can you take it forward? I don't see any questions in the chat box also. So over to Dr. Dashna for the next lecture. Thank you so much for your kind.
हेलो दर्शना मैम
हाँ बेटा हाय मेरे को नए वो मिल गए
दर्शना मैम आपकी ऑडियो नहीं आ रही प्लीज अनम्यूट मैम ऑडियो नहीं आ रही है आपकी
Okay.
Okay, thank you. Good afternoon. Good afternoon, everyone. I am Dr. Darshna Jain, and I will be presenting a talk on reagent lot verification. So before I start my presentation, I want to say thanks to organizer for giving me this wonderful opportunity to share my thoughts in the scientific community of laboratory medicine. Actually, this topic is quite dry in a way, and it is quite relevant also because in biochemistry, we have two kinds of method. One is dry chemistry and other one is liquid or wet chemistry. So I will try to justify it and see that I can make a difference with this. So thank you so much. So let's start. It is essential that clinical laboratories achieve consistent and a reliable test result. Sorry for interrupt you. Sorry for interruption. Sorry for some technical adjustments. Sorry. Once again. It is essential, let's start. It is essential that clinical laboratories achieve consistent and reliable test results. Tests performed using a modern automated chemistry analyzer involve the instrument, the calibrator, and one or more reagent. Reagent lot changes occur relatively frequently because large amount of reagent are used for short periods. Therefore, to ensure the consistency of the test result of a clinical laboratory, the result before and after reagent lot changes should be analyzed at the statistical level. Kindly change my slide.
No, ma'am.
क्यों चेंज नहीं कर पा रही हूँ मैं?
No,
Hmm.
introduction slides only.
Thank you. For this reason,
Ma'am, change the.
हो गया. Thank you. For this reason, the inspection checklist of the College of American Pathologists require that when there is a reagent lot change, a certain number of patient specimen and 2 to 3 level of quality control material should be tested with the new and old reagent lots. When differences in the result measured using new lots and old lots meet the acceptance criteria in each laboratory, the test results are considered as consistent irrespective of reagent lot changes. Although acceptance criteria vary from laboratory to laboratory, a new lot is generally considered to be acceptable when the result of the patient specimens obtained with a new lot do not differ from those with the new old lot. Both lots are same. Result of both lots are same. The QC material values obtained with the new reagent lot fall within the predefined QC material target range of the old reagent lot. The validation process can be passed only when these both criteria are met. Now comes to reagent lot. What do you mean by lot, and what is reagent lot, and what do you mean by reagent lot change? Reagent lot to lot variation may be defined as a change in the analytical performance of the reagent from one production lot to the next. Here we use to the term lot. So what do you mean by lot? Lot mean a batch of reagent produced by the manufacturer under uniform conditions and passing as a unit through the same series of processes. And what do you mean by lot change? The realities of the reagent preparation process mean that there will always be some differences between reagent lots. The standard use in laboratory is the new reagent lot was considered to be acceptable if the same patient specimen tested with the new and old reagent lot return value do not differ by more than 10%. 10% is that line. The value obtained by testing the QC material with a new lot reagent fell into a conventional predefined target range. We were able to confirm that reagent lot testing in laboratory satisfied all acceptance criteria and met the requirement of Clinical American of Pathologists CAP criteria. However, these criteria are the minimal requirement as practice guideline and insufficient as a standard of optimal laboratory practice. So, two factors are more important in case of reagent lot changes. The factor one is the ratio of within lot and between lot variation. This ratio is very, very important. And second one is the typical measurement frequency of individual within an average length that a lot is in use, which is often determined by policies of supplier and or laboratory. So now comes to first factor, factor one, which is the ratio of within lot and between lot variation. Now I explain. A reagent lot change become apparent when the persistent random error due to the between lot variation is larger than the usual within lot variation. Nowadays, this has become more apparent due to achievement in minimizing within lot variation by in vitro diagnostic manufacturers, resulting in similar within lot variation for different lots. Whereas in within lot variation is mostly dependent on mechanical and optical instrument in precision. ज्यादातर हम हमारे क्लिनिक लेबोरेटरी सेटअप में इंस्ट्रूमेंट ऑप्टिकल इंस्ट्रूमेंट हम यूज कर रहे हैं तो फिर इज विद इन लॉट वेरिएशन इज मोस्टली डिपेंडेंट ऑन मैकेनिकल एंड ऑप्टिकल इंस्ट्रूमेंट whereas between lot variation is caused by the manufacturing process of reagents and calibrators. In the case of calibrator, by their subsequent value assignment. Although manufacturers are formally required to adhere to an auditable traceability chain, which is very, very important, and recent development of ISO 175-11-2020 on metrological traceability in laboratory medicine makes these requirements even sharper. These chains are often longer than necessary and may use calibrator material with uncertain commutability, resulting unnecessary impact on the measurement uncertainty. Therefore, the ratio of within lot and between lot variation can indicate, although indirectly, the likelihood of incorrect medical decision making based on lot effect. This is applied part of reagent lot changes. So why reagent lot changes is much important for clinical diagnosis or for the point of view of clinician. Now comes to the second factor. Second factor is the typical measurement frequency of an individual in a typical period of lot use. The relevance of reagent lot difference is dependent on the ability of requesting clinician to form a customary feeling of the patient variation. A feeling of usual variance aids clinician in recognizing pattern in patient which warrant clinical decision. In addition, patient track their own laboratory result, where a sudden change in outcome may come stress and anxiety. अभी जो फिलहाल अभी वर्तमान में नाउअडेज अभी जो प्रैक्टिस अभी चल रही है सारी अभी क्लिनिकल लेबोरेटरी बेस्ड ही है. सारे क्लिनिशियन डायग्नोसिस पर कहीं ना कहीं हमारे लेबोरेटरी पर हमारे सारे इन्वेस्टिगेशन पर ही बेस्ड है. तो अगर कुछ भी हम ऐसे रॉन्ग डायग्नोसिस हमारे इन्वेस्टिगेशन के कारण होता है तो एक वो बड़ा स्ट्रेस और एक ट्रॉमा और एंजाइटी और एक हर किसी पेशेंट का भी एक अपना एक टॉलरेंस लिमिट है. सिमिलर सिचुएशन मैंने कुछ दिनों पहले ही पर्सनली मैंने फेस करी थी जब भी मैंने अपना ग्लाइकेटेड हीमोग्लोबिन एक रूटीन एक मैंने इन्वेस्टिगेशन कराया था, मेरी ही लैब में कराया था मैंने. तो उसमें भी कुछ इस तरह की प्रॉब्लम के कारण मुझे हायर साइड मुझे मेरे ग्लाइकेटेड हीमोग्लोबिन की वैल्यू मिली. तो जो मुझे एक थोड़े देर के लिए फिर मैंने अपना मैनेजमेंट पार्ट अप्लाई करा और क्यों आया, बट थोड़ी देर के लिए मुझे एक टेंशन और स्ट्रेस और एंजाइटी सारा फील मैंने पर्सनली करा है. तो ये हम इसको बहुत अच्छे से समझ सकते हैं कि एक क्यों हमारे लिए इम्पोर्टेंट हो जाता है. इन प्रैक्टिस द यूजुअल वेरिएंस इन अ स्टेबल पेशेंट is a combination of within patient biological variation and analytical variation, which can either be within reagent lot or combination of within and between reagent lot variation. So what occur? Change in the analytical performance of a reagent from one production lot to the next affect QC, quality control, and of patient result. So that's why it is very important. So let's see one real world example. Here we can see example of brain natriuretic peptide, VNP. Here the lab received the new lot and perform 5 patient sample with old lot and new lot. So the observed value of VNP is less than in new lot as compared to old lot. And its range between -11 to -24. The target value of BNP provided by CLIA is -30 degree. So what's your opinion? Can we use the new lot to report patient result? आप मुझे मैसेज कर सकते हैं. So I would like to revisit the real world example. We have not yet implemented moving average and thus we rely on patient comparison studies to identify clinically significant shift associated with new reagent lots. The differences we observe for patient result between one current lot and new lot of reagent were quite striking and on the borderline of acceptability based on our predefined total allowable error criteria. While the clinical management of most patients would not have been altered with this new reagent lot. We remain worried about the contribution of this lot to long-term drift in patient result. In the end, we decided to contact the manufacturer and requested a different lot of reagent. Keep in mind, though that an alternate lot of reagent may not always be immediately available. So some alternate option that you may consider in this case include sending out the testing to a nearby laboratory or removing the observed bias by applying a mathematical factor to the result that are obtained with the new reagent lot. Here, we are discussing some causes of lot-to-lot variation. There are so many causes of lot-to-lot variation at the level of manufacturer, at the level of shipping and storage, and at the level of laboratory itself. At the level of manufacturer, we are facing some problem in reagent composition. Reagent भी बहुत सारे different raw materials हम use करते हैं reagent में. Reagent stability ये बहुत important हो जाती है. मैन्युफैक्चरर उसको कैसे स्टोर कर रहे हैं, कैसे सारे उसका रिसोर्सेज है, क्या क्या इंफ्रास्ट्रक्चर है, तो उस पर डिपेंड करेगा स्टेबिलिटी. कम्स टू शिपिंग एंड स्टोरेज. शिपिंग एंड स्टोरेज डिपेंड्स अपॉन टेम्परेचर, ह्यूमिडिटी, टाइम, एजिटेशन. अगर हम बात करते हैं हमारे इंडियन सिनारियो में तो ये बहुत एक बड़ा फैक्टर हो सकता है। टेम्परेचर डिफरेंस अभी आप देखिए तो हमारा कुछ भी क्लासिकल पैटर्न अभी इंडिया में अभी बचा नहीं है। अगर हम टाइम की बात करते हैं उदाहरण के तौर पर, तो हम देखते हैं कि अभी कुछ भी आप मीडिया में आए दिन पढ़ते रहते हैं, कभी ट्रांसपोर्ट की स्ट्राइक हो गई ड्यू टू एनी रीजन, कुछ ट्रांसपोर्ट में हर्डल्स आ गए, नहीं पहुंच पा रहा है। अभी मैं गवर्नमेंट सेटअप में हूं, तो अगर मैं गवर्नमेंट सेटअप की बात करें तो पेपर वर्क के कारण भी बहुत सारी चीजें अटक जाती हैं। सब कुछ चीजें हमने अप्लाई करा हुआ है बट अभी आना है, अभी टेंडर भरेंगे, अभी वेंडर ये कर, तो हो सकता है कि एक बहुत बड़े टाइम आपका एक मैन्युफैक्चर और हमें जब रिसीव होता है सैंपल, उसमें एक बड़ा आपको एक इंतजार करना पड़े एक टाइम। एट द लेवल ऑफ लेबोरेटरी लेवल पे हम फेस करते हैं कैलिब्रेशन इज वेरी बिग इशू। अगर हो सकता है कैलिब्रेशन के बाद में कुछ प्रॉब्लम्स आ रही हो, कब कैलिब्रेट हुआ है। डेड वॉल्यूम, कई बार हम देखते हैं कि बहुत सारे लास्ट का जो एक थोड़ा सा वॉल्यूम बचा है तो उसमें हमें कुछ चेंजेस में से मिल रहा है। स्टोरेज का भी एक प्रॉब्लम लेबोरेटरी के लेवल पर भी होता है, कैसे हम स्टोर कर रहे हैं, वहां के क्या टेम्परेचर कंडीशन है, कितने हमारे जो स्टाफ है वो ट्रेंड हैं। तो दीज आर सो मेनी कॉजेज ऑफ लॉट टू लॉट वेरिएशन। सो व्हाई डज लॉट टू लॉट वेरिएशन अकर? In an ideal world, each lot of reagent and calibrator produced by a manufacturer would be identical, which would allow for the laboratory to seamlessly transition from one lot to the next with no noticeable change in patient result. Unfortunately, the realities of the reagent preparation process mean that there will always be some differences between reagent lot. These differences tend to be more marked in case of immunoassay than for general chemistry assay. Why? Because the production of an immunoassay reagent involves the binding of antibodies to a solid phase. The quantity of antibody bound to the solid phase will inevitably be slightly different for each batch of reagent. Even when external factors such as temperature, pH, and concentration of reagent constant are same or keep constant. So clinically significant lot-to-lot variation when undetected can cause change in result, which may present a risk to patient care. These are the clinical consequences of lot-to-lot variation. For example, Thaler et al. Report a case in which change in glycated hemoglobin reagent lot led to an average increase in patient result of 0.5%. A change of this magnitude may lead to patient being incorrectly diagnosed with diabetes mellitus and erroneously started on medication. Undetected lot-to-lot variation has also been reported for insulin-like growth factor also. In the case described by Algeciras-Simon, the discrepancy went unnoticed despite the laboratory utilizing an evaluation procedure for new lot of reagent and was brought to the attention of laboratory staff by clinician noticing an unusually large number of discrepant results. Lot-to-lot variation affecting several lots of prostate-specific antigen reagent in use of assay pathology lab was responsible for the release of falsely elevated PSA results, causing undue concern for patients who had undergone prostatectomy. As such, as result would be suggestive of a recurrence of prostate cancer. So lot-to-lot variation is not problem restricted to the biochemistry laboratory. Lot-to-lot variation has also been described in other branches of laboratory medicine, including hematology and serology also. So procedure for the identification of lot-to-lot variation will vary depending upon the nature of the analyte in question, and therefore processes developed for other discipline may not be appropriate for use in the biochemistry setting. Now comes to the different approaches of new lot validation. So let's see approach one. So first we should establish acceptable performance criteria. acceptable performance criteria maintained or established on the basis of clinical requirement, on the basis of biological variation, on the basis of analyzer performance. And we should also decide or select target concentration. So what are the bases of target concentration selection? Target concentration select on the basis of reportable range, medical decision limits, and we also analyze 5 to 20 patient sample with both lots, new lots and both old lot. So here we can see greater number of sample is equal to higher likelihood of bias detection. जितना ज़्यादा हमारा हम sample analyze करेंगे, उतना हमारा bias detection के chances ज़्यादा होंगे. So here on the basis of all these measures, we would like to decide this lot is accepted or rejected. So here we can see approach 2 of new lot validation. We can see here if analyte is unstable or laborious or infrequently performed, we only have to perform 4 quality control analysis of each level, level 1 and level 2. We do not have to perform patient specimen analysis in this case. In case of if our analyte is stable, generally no quality control or patient shift with new reagent lot. In this case, we do 4 quality control replicate of each level, level 1 and level 2. And in this case, we have to do patient specimen analysis also. For 10 retained patient specimen, we can do. If quality control rule violation or persistent shift in 48 hours following lot change we find. In this case, we only can perform patient specimen analysis. In this, if our analyte is sometime demonstrate clinically important lot-to-lot variation in patient specimen with new reagent lot, in this case, we also perform 10 retained specimen with each new lot and quality control replicate of each level, level 1 and level 2. So you can see quality control analysis तो हमें हर एक situation में करना ही है दोनों level के control के साथ में, but patient specimen analysis हम decide करेंगे हमारा पेशेंट हमारे ऑन द बेसिस ऑफ आवर एनालाइट कि अगर सेकंड और थर्ड सिचुएशन में आप देख रहे हैं कि हमें पेशेंट स्पेसिमेन एनालिसिस करने की जरूरत है, अदरवाइज क्वालिटी कंट्रोल एनालिसिस का इनफ. Now comes to regulatory requirement for the lab. CLIA 88. What's a CLIA 88? Section 493.1255 calibration verification must be performed whenever a complete change of reagent occur. Unless the laboratory can demonstrate that changing reagent lot numbers does not affect the range used to report patient test result, and control values are not adversely affected by reagent lot changes. And Clinical American of Pathologist, com.30450, new reagent lot and or shipment are checked against old reagent lot or with suitable reference material before or concurrently with being placed in service. Now comes to CLSI. What do you mean by CLSI? CLSI is Clinical and Laboratory Standard Institute. CLSI procedure for the evaluation of new reagent lot says precision data is used to determine the repeatability and within reagent lot standard deviation. Desired statistical power is determined. Lookup tables are used to determine. How can we determine? The number of sample required at each target concentration on the basis of rejection limit, on the basis of actual statistical power obtained by the evaluation. When it comes to samples are selected and measured on each reagent lot. So the mean difference between results for the current and new lot at each target concentration are compared with the rejection limit. all differences are less than the rejection limit, then the new lot is accepted for use. So rejection limit is very important. If any of the differences are greater than the rejection limit, then the new lot has failed the evaluation and must not be used until further troubleshooting has been carried out. So how can we select a sample? Selecting sample for the lot evaluation. There are a number of description of different sample type. We prefer to use individual patient sample as these best reflect clinical practice and avoid the commutability limitation of quality control material. Quality control material is another sample type that could be considered once the described limitation have been considered and tighter target applied. The patient sample are chosen according to expected patient's value. Clinical laboratory reagent contain a variety of substance incorporated for a variety of reasons. Some are related to the intrinsic sensitivity and specificity of the measurement process. For example, in immunoassay, reagent polyclonal antibodies are generally extracted from animal blood, while monoclonal antibodies are purified from tissue culture media. Other components affect solubility, storage, stability, viscosity, and other properties needed to test sample using the automated equipment of modern clinical laboratories. When current batches of reagent become unavailable because of inventory exhaustion or other reason, new batches are manufactured. So how can we assess of new reagent lot changes? Commutability is a property of reference materials, including quality control sample, such that the differences between result when tested using two or more different test procedure for the same analyte are close to the differences seen on patient sample. Thus, the relative difference between results of patient sample tested with two separate lots of reagent would be comparable to the differences in result obtained using samples of commutable material. But commutability of QC material is not a given because the composition of QC material differs significantly from that of patient sample. While analyte contained in patient sample is highly variable and their stability is ephemeral. QC samples are manufactured with the purpose of maintaining a fixed and stable level of analyte. Here, peer laboratories can enhance their assessment by the aggregation of their result. A recent article in Clinical Chemistry and Laboratory Medicine described the one-year experience of 27 laboratories participating in a Norwegian organization of laboratory examinations program that gathered patient sample result from the evaluation of 28 to 29 reagent lot changes for 5 tests. The mean differences between lots range from 2.2% for HbA1c to 5.5% for D-dimer. So how can we tackle reagent lot-to-lot verification? Clinical laboratory practices for lot-to-lot evaluation also vary widely, ranging from testing as few as 3 to 4 samples to as many as 20 to 40 samples with each new reagent lot. Regarding the choice of sample that are tested, current approaches include the use of QC material supplied by the reagent vendor, third-party QC material, in-house QC material, and patient sample. Caution should be taken if only QC material is used for lot verification. Matrix-related differences between patient samples and QC material could affect how well QC results reflect new reagent lot performance in actual patient sample. When patient sample comparison are used, the type of sample tested again varies significantly between laboratories. Some lab tests might test with low, mid, and high analyte concentration. Other might test randomly selected patient sample, while still other might test sample with values that span an analytical measurement range. There are no universally agreed upon acceptance or rejection criteria for new reagent lot. It is up to the laboratory management team to determine what is acceptable. The decision should be based on the historical performance of the assay, the assay imprecision, and the estimated allowable overall bias for the respective analyte, given its biological variability and clinical use. To date, there has not been a standardized protocol or guideline to help laboratories deal with lot-to-lot verification. Recognizing the need for one, the Clinical and Laboratory Standard Institute recently published the document. This guideline offer a practical protocol that takes into consideration the resources constraint of the clinical laboratory and uses as few patient sample as possible. In practice, the protocol is broken down into two phases. In first phase, which could be time consuming, but once established does not need to be repeated, involve gathering data to establish a number of parameters. These include the maximum difference between the two reagent lot that would be acceptable without having an adverse clinical impact or critical difference. The laboratory observed method, imprecision, and the desired statistical power for detecting significant lot-to-lot changes. This information is then used to determine the number of samples to be tested and the rejection limit necessary to assure the critical differences is detected. And in second phase involve verification of the new reagent lot by testing the determined number of patient sample with both lots of reagent, calculating the average concentration difference between the two lots. The analyzing acceptability of the new lot based on the rejection limit established during the first phase. Lot-to-lot verification is without a doubt necessary to prevent use of suboptimal reagent lot, but it can be an additional burden to the laboratory, especially when it takes multiple attempts to obtain an acceptable reagent lot. Laboratory needs to plan ahead and allow time for performing repeat new reagent lot evaluation if acceptability limits are not initially met. Accessibility to the necessary number of patient sample, availability of resources such as instrument time, remaining inventory of the current reagent lot, and technologist time will need to be taken into consideration. With EP26A, laboratory will be able to adapt a standardized and practical process for lot-to-lot verification in keeping with resources constraint limit of the current healthcare environment. Here we can see in this table uh, below contain information on clear testing criteria for acceptable analytical performance. These guidelines for acceptable performance can be used as analytical quality requirement in the Westgard quality control design and planning process. So we must know about it and adhere with these guidelines. Now, I will summarize my topic. Now come to the evaluation for lot changes. With every change in lot of reagent or calibrator, there is a possibility that clinically significant lot-to-lot variation may be present. Therefore, a full evaluation of each new lot should ideally be carried out. Furthermore, it is requirement under ISO 15189 that each new lot or shipment is acceptance tested prior to use. However, it must be noted that some laboratories struggle to fulfill their requirement. The necessity for just-in-time reagent ordering practice as take place in some of the larger laboratories mean that it can be difficult to complete a thorough evaluation of a new lot prior to it being put into service. And third but not least, evaluation is usually not required when changing to a new bottle of reagent or calibrator from the same lot, as the constituent of each bottle within a lot should be almost identical with a negligible impact on patient result. If there is significant vial-to-vial instability, this can be checked with internal quality. So my talk is over. Thank you. Thank you for listening me.
So very good afternoon to one and all present here. At the outset, I would like to thank Dr. Neeraj Jain, sir, for giving me this opportunity today. And today my topic for the presentation is unveiling therapeutic strategies against MDR pathogens, which is mainly an insight from a medical microbiologist point of view. So this will be the structure of my presentation. And as we all know, there are various groups of resistance organisms like multi-drug resistant pathogens, extended drug resistant pathogens, and pan-drug resistant pathogen. And to see the definition of each, so we call an organism to be a multi-drug resistant when the organism is resistant to drugs in at least 3 or more antimicrobial classes. Like if we take, for example, penicillin groups, cephalosporin groups, aminoglycosides, and fluoroquinolone. So when it is resistant to 3 or more antimicrobial categories, we call them as MDR pathogens. And when the organism is resistant to most of the agents in almost all the classes, but sensitive to at least 1 or 2 class of antimicrobials, we call them as XDR pathogens. And pan-drug resistant PDR pathogen are organisms which are resistant to all the agents in all the antimicrobial categories. Now, why we are more bothered about these MDR pathogens? Because as we all know, they cause prolonged illness, which are very difficult to treat with limited therapeutic options, which also accounts for a high medical cost associated with high mortality and morbidity. And these are mainly targeting the immunocompromised hospitalized patients. And when we see an organ or a patient to be suffering from a multi-drug resistant infection, on what basis you decide the treatment options? Are there treatment options for treating these pan-drug resistant organisms? If so, what is the rationale behind which you select the treatment options? And do you think the microbiologists have a role in guiding the treatment? So all this will be clarified in my subsequent slides. So first we'll start with understanding some of the common mechanisms of drug resistance. So the 3 common mechanisms of drug resistance are, the first and the foremost important component is enzyme-mediated resistance. That is resistance because of production of certain enzymes by the pathogens. The next common mechanism is porin channel mutation, which results in altered absorption or intake of the drug. And third one is the efflux pump regulation, where because of the overaction of the efflux pump, the antibiotics which has entered into the antimicrobials which has entered into the organism is pumped out so that they are not effective against the pathogen. So these are the 3 common mechanisms of resistance which are operating in any pathogenic microorganism. Among these, it is the enzyme-mediated resistance, which is the most commonest mechanism. And if we consider the various enzymes which are operating in the organisms, these enzymes responsible for resistance can be categorized into 4 classes, which are class A, class B, class C, and class D. Now, the class A includes your extended spectrum beta-lactamase enzymes, which are in short called as ESBLs, which acts on all classes of cephalosporins up to the 4th generation, as well as the monobactams. And these enzymes are inhibited by certain inhibitors like beta-lactamase inhibitors like clavulanic acid, tazobactam, or avibactam combinations. And the next most important enzyme coming under the class A is a carbapenemase, which is called KPC carbapenemase, which acts on carbapenems. They are able to hydrolyze carbapenems, but they are weak hydrolyzers of carbapenems, and they even act on monobactams. And even these enzymes are inhibited by clavulanic acid, tazobactam, and avibactam combination. The next important class is class B, which includes your metallo-beta-lactamases, which acts on carbapenems. That is, they act on all the drug classes until up to carbapenems. But they don't act on monobactams, which is Astriona, and they are inhibited only by EDTA. Next, coming to class C, it includes your AMC beta-lactamases, which inactivates all your cephalosporins, even your BL-BLI combinations like amoxiclav, piperazolone, tazobactam, cefiperazone, sulbactam, as well as your monobactams. And there are no inhibitors available to block this type of enzymes. And class D mainly includes your OXA enzymes. The 2 main classes are OXA 11 and 15, which are extended spectrum cephalosporinase enzymes. The other one being your 23 and 48, which are weak carbapenem hydrolyzers. And both class B and class D OXA23, they don't act on monobactams, which is they don't inactivate aztrionomes. So these are the most important classes of enzymes which are involved in producing resistance in most of the commonly encountered pathogenic microorganisms. Now, the highest level of resistance encountered in a pathogen is the carbapenem resistance. And the various mechanisms for this carbapenem resistance could be either it could be due to a production of enzyme called carbapenemases, or it could be due to porin channel mutation or efflux pump up regulation, or it could also be due to overproduction or co-production of ESBL or AMPC enzymes. So in carbapenemases, we have enzymes which belong to class A, which is KPC carbapenemases, class B, which are MBL, and class D, which are OXA48-like enzymes. And remember, these are the three major classes of carbapenemases which are responsible for carbapenem resistant among pathogens, which is either Enterobacteriaceae or non-Enterobacteriaceae. And less contributed mechanisms for resistance include your porin channel mutation, efflux pump, and co-production or overproduction of other non-carbapenemase enzymes like ESBL and AMPC enzymes. Now, once we understand these resistance mechanism, then by reading a culture and sensitivity report, we can get an idea on the various other available treatment options to treat these multi-drug resistant organisms. And before going to the treatment options, I would like to also highlight on the stewardship measures. And now the current concept is on AIDS stewardship. AIDS stewardship is nothing but it is an integrated approach which integrates all areas of infection management, starting from your diagnosis, treatment, and prevention point of view. So AIDS stewardship stands for antimicrobial stewardship, infection prevention stewardship, and diagnostic stewardship. And together, these are called as diagnostic approach. And remember, before going on to treat the multi-drug resistant pathogens, our first and foremost aim should be to prevent the emergence of these multi-drug pathogens, which should always be done with the stewardship measures. And therefore, whenever we are involved in patient care management, right from the diagnosis, treatment, and all aspects of patient care management, stewardship should be an integrated part of patient care management. Now, what is this diagnostic stewardship? Diagnostic stewardship is a stewardship measures which is implemented in the diagnostic protocol which is followed for the patient. Like it includes the pre-analytical, analytical, and the post-analytical phases. The pre-analytical phase includes making a correct clinical acumen in deciding whether the patient is suffering from an infectious disease or not. It also includes ordering the right test for the patient. Once the test is ordered, collecting the right sample for the patient, and the timing of collecting the sample also plays a very significant role in influencing your result. So all this is included in the pre-analytical diagnostic stewardship. So remember, when you put a garbage inside a test, it's only the garbage out you expect from the diagnostic test. And the post-analytical stage includes the correct interpretation of the report which has been released from the laboratory. When all these are followed properly, we can decide whether the patient is having an infectious disease or not, or whether the sample has been collected properly or not, and whether an antibiotic is actually needed to treat the patient or not. IPC stewardship is nothing but infection prevention and control stewardship, which is implementing the standard precautions as well as the transmission-based precautions at all levels wherever is possible. Therefore, we try to reduce or avoid the infection and thereby decrease the use of antimicrobials, thereby contributing to the reduced emergence of multi-drug resistance pathogens. Now, I'll take you through some of the case scenarios to understand better about the therapeutic options available for treating these multi-drug resistant pathogens. So this is a case history where a sputum sample was collected from a 72-year-old diabetic male. He complains of cough for the past 10 days and sputum was sent for culture and sensitivity. And this is the gram staining report which has been released from the laboratory, and the culture shows an MDR E. coli with the following antimicrobial susceptibility pattern. So what will be your clinical management? So here, when you see properly, whenever a culture and sensitivity report is interpreted, give importance to all the aspect of the report. First, start from concentrating on the gram stain. And the gram stain which has been released in the report clearly says there were many epithelial cells and very few pus cells, which means the sample collection was not proper. So it was not the sputum sample which was collected from the patient. It was only a salivary sample which was released in the laboratory, which was received in the laboratory. So the sputum sample was contaminated with saliva, and that is why the gram stain shows many epithelial cells and very few pus cells. So when you see such type of gram staining report, it means the sample collection itself was not proper, and whatever organism has been given in this report and the AST, it could not be interpreted or correlated with the clinical findings of the patient. So on the first observe the gram stain, and here it says the sample collection was not proper, and therefore there is no use in treating this patient, even though the culture report shows it is an MDR E. coli. So here, if I were supposed to treat this patient, I would discard this result and I will not treat the patient. Either I will go for a repeat sample, instruct the patient about the proper sample collection, send a repeat sample to the laboratory and get a proper report, or based on the clinical condition, I would like to take my decision. The next clinical history shows a pus sample was received from the patient who has undergone a fracture fixation, and which shows the following antimicrobial susceptibility report. So specimen is pus, and the gram staining shows gram-positive cocci with pus cells, and the culture shows heavy growth of Staphylococcus aureus. So the Staphylococcus aureus which is grown, and it shows the following antimicrobial sensitivity report. And whenever a Staphylococcus aureus report has been released, concentrate on one particular drug, which is cefoxitin. This cefoxitin will say whether the organism is methicillin resistant or methicillin sensitive. When cefoxitin is reported as sensitive, it means it is a methicillin sensitive Staphylococcus aureus. When cefoxitin is reported as resistant, it is a methicillin resistant Staphylococcus aureus. So all Staphylococcus report first try to concentrate on the cefoxitin sensitivity result which is released from the laboratory and decide whether it is a methicillin sensitive Staphylococcus aureus or a methicillin resistant Staphylococcus aureus. Because this categorization initially based on the cefoxitin drug helps us to avoid the use of vancomycin in most of the patient. Because nowadays we see any Staphylococcus aureus report which is released from the laboratory, irrespective of the sensitivity pattern, most of the patients get treated with vancomycin, which is absolutely not needed. So see whether it is a methicillin sensitive Staphylococcus or a methicillin resistant Staphylococcus. And if you think, so here the patient is suffering from a methicillin sensitive Staphylococcus aureus infection. So though vancomycin is reported as sensitive, try to avoid vancomycin in these cases, because when you give vancomycin in MSSA isolates, studies reveal that it is associated with more clinical failures. So there are various options which are available to treat methicillin sensitive Staphylococcus aureus. So when you see a penicillin resistant cefoxitin susceptible strains, avoid using vancomycin. Instead, you can go for any of these group of drugs which are given here as a treatment option based on the sensitivity report. You can use penicillin stable penicillins like floxacillin, flucloxacillin, difloxacillin, or you can go for a beta-lactamase inhibitor combinations. You can even go for anti-staphylococcal cephalosporins and a carbapenem. So these are the various treatment options which are available to treat MSSA. So therefore, it is not the vancomycin which is the only treatment of choice when you see the report as Staphylococcus aureus. Now suppose, and the same report said it was cefoxitin resistant, then we know the organism is methicillin resistant Staphylococcus aureus. So you cannot use any of the beta-lactam group of drugs, and therefore you need to go for different treatment options. And again here, it is not the vancomycin which is only treatment option which is available. Look for the sensitivity report. Based on the sensitivity report, there are even other treatment antimicrobial classes which are recommended for treating methicillin resistant Staphylococcus aureus. And whenever you see all the other drugs are resistant and you are left only with vancomycin as a treatment option, when you are using vancomycin for the patient treatment, then please concentrate on the MIC of the agent. When the MIC, many studies show that when the MIC is below 1.5, you have clinical success. But when the MIC is above 1.5, that is between 1.5 to 2, though the vancomycin is reported as sensitive, this is associated with many clinical failures. There is a mechanism which is called as MIC creep, where the MIC slowly shifts to the higher side during the course of treatment. So whenever the vancomycin is given for the patient treatment, please look into the MIC values. When the MIC is below 1.5, you are safe. If it is between 1.5 to 2, reconsider using your vancomycin because this is more commonly associated with clinical failures. Next, coming to the next case, here you see a 32-year-old female presenting with urinary tract infections. So urine was collected and it was sent for culture, and it shows the following antimicrobial susceptibility report with the organism being reported as Escherichia coli. And again, urine is one of the most commonly received sample in any laboratory. And whenever urine sample has been sent and you receive a culture report, please make sure the patient complains of urinary tract infection. Please don't send urine culture for any patient with asymptomatic infection. If the patient doesn't complain of any urinary tract infection, don't send a urine sample as a routine. And even if you have sent the urine sample as a routine, which is included, for example, if a patient undergoes a master health checkup, its urine culture is included as a routine in that. And when you get the report in the urine culture, even though the urine culture shows a colony count and the significant levels, when the patient doesn't complain of any urinary symptoms, please don't treat the patient. So asymptomatic bacteriuria doesn't need any treatment except under few clinical conditions, even though when the count is present in the significant load. So now here the patient had urinary symptoms. So therefore the sample was sent for culture. And now the colony count is more than 1 lakh, which means it is significant. So you have to consider the organism as a cause of infection. The organism isolated is a gram-negative bacilli, which is Escherichia coli. And when you look into the AST pattern, you can see the organism is sensitive to aminoglycosides. It is resistant to penicillins as well as to all the cephalosporins up to the 4th generation cefepime. And once the organism is resistant to all the cephalosporin, then go on to look into the report of BL-BLI combination. And here, if you look, all the BL-BLIs are sensitive, like amoxiclav, cefoperazone, sulbactam, and PIT, it's piperazine, tazobactam, all these are sensitive. And in addition, you also look for urine-specific drugs whenever urine sample has been sent. So look for netilmycin is sensitive, nitrofurantoin is sensitive, norflox, zooflox, all those have come as sensitive. So when you look, all the penicillins and cephalosporins till the 4th generation has come as resistant. The BL-BLIs and other group of drugs are sensitive. So first, whenever you see a culture and sensitivity report, analyze and learn to study the resistance pattern exhibited by the organism. So from the AST report here, the resistance pattern which is exhibited by the organism is a ESBL production, extended spectrum beta-lactamase producing organism. So organism is an ESBL producing organism, which means you cannot give any of the cephalosporins. But in the table which I showed in the initial slides, we know this ESBL enzyme is inhibited by clavulanic acid, sulbactam, and tazobactam. And therefore, the treatment option for this group of pathogens will be your BL-BLI combination drugs like amoxiclav, cefoperazone, sulbactam, or piperazine, tazobactam. But when it is an urinary tract infection, instead of going to this BL-BLI combination, based on the sensitivity, you can go for, as a first-line treatment, always prefer using either a nitrofurantoin, cotrimoxazole, or even a single-dose aminoglycoside is what is recommended by the guidelines for treating these ESBL-resistant, ESBL-producing pathogens. So based on the syndrome, based on the side effector, if it is a urinary tract infection, avoid using higher drugs, and you have a lot of options with the lower class of drugs like nitrofurantoin, cotrimoxazole, or go for a single dose of aminoglycoside based on the renal functions of the patient. And in case of pyelonephritis, again, if it is a urinary tract infection, differentiate whether it is a cystitis or a pyelonephritis. And if it is cystitis, you can go for urinary concentrating antibiotics. But if it is a pyelonephritis, you don't have those drugs as options. So you have to go for other alternative higher drugs based on the resistance pattern. The next case scenario, again, here the patient is complaining of urinary tract infection. Urine has been sent for culture. And now the organism, what we see here we have a significant count of, again, Escherichia coli, which is reported from the patient. And now we go on to analyze the AST report. Here we see penicillins are resistant, cephalosporins are resistant. One cephalosporin are out. Next, look for BL-BLI combination. And here, if you see, all the BL-BLIs are also resistant. So whenever an organism is resistant to all these cephalosporins and BL-BLI combination, it means the organism is an AMP-C beta-lactamase producing organism, which belongs to class C antibiotic neutralizing enzymes. So this organism is an AMP-C beta-lactamase producing organism, and therefore whenever an organism is AMP-C beta-lactamase producing, then you have only option which is left with, which are your carbapenems. And sometimes when cefepime or the 4th generation cephalosporin is reported as sensitive, studies say these AMP-C beta-lactamases are better treated with cefepime as a carbapenem sparing measure. So when you think the organism, when you see the report organism is resistant to cephalosporins and BL-BLI combination, look for the sensitivity report of cefepime. When the cefepime is reported as sensitive, don't think you cannot use cefepime. Actually, AMP-C beta-lactamase enzymes will not neutralize 4th generation cephalosporins. So 4th generation cephalosporin, cefepime is a good treatment option for treating this AMP-C beta-lactamase, so that you can avoid using carbapenem as a carbapenem sparing measure. So these are the various treatment. If cefepime is sensitive, use cefepime, avoiding carbapenems. And based on the sensitivity of other groups, you can also use cotrimoxazole or fluoroquinolones if they are given as sensitive. And there are certain group of drugs which are called as inducible AMP-C pathogens, which means there are certain pathogens. For example, these are called as spice pathogens, which includes your Serratia, Enterobacter providentia, indole negative protease species, Enterobacter and Citrobacter species. Previously, it was called as spice pathogens, but now the new guidelines say it's only 3 organisms which are considered as inducible AMP-C beta-lactamase producing pathogen, which is your Klebsiella aerogenes, that is your Enterobacter aerogenes, Enterobacter cloacae, and your Citrobacter fruendi. So when you encounter these 3 clinical isolates in any clinical sample in the culture, though the report can be sensitive to all the cephalosporins which are available, think before using cephalosporins as a treatment option for treating these pathogens, because these pathogens are potent inducible AMP-C beta-lactamase producing organism. Inducible means when you expose these organisms to cephalosporins, there are certain drugs. These drugs induce the production of AMP-C beta-lactamase in these organisms, and therefore during the treatment process, they become resistant to these drugs, and therefore you encounter a multi-drug resistant pathogen during your treatment time. And therefore, whenever you encounter these 3 organisms, Enterobacter aerogenes, Klebsiella cloacae, and Citrobacter fruendi, please consider them as inducible AMP-C beta-lactamase producing organism. Even though your report gives all the cephalosporin as sensitive, avoid using them for the treatment purpose. Then what are the drugs which can be used for treating these pathogens? So the best treatment options will be your 4th generation, because as I've told you, 4th generation cephalosporin cefepime is not acted upon by AMP-C beta-lactamase. And therefore, cefepime becomes your best treatment option. If cefepime cannot be used, then the other treatment options would be your imipenem or any other carbapenems. But try to use carbapenems in these class of organisms as far as possible. Therefore, best option will be cefepime if it is sensitive to cefepime. If you don't have any other option resistant to all the groups of drugs, then you can think of carbapenems in this group of patient. The next case scenario is a 63-year-old male patient admitted to ICU with post-operative wound infection. The patient progressed to sepsis. So pus and blood were sent for culture, and both the samples grew Klebsiella pneumoniae with the following antimicrobial susceptibility report. So here, if you see, the pathogen is resistant to almost all the available drugs. It is sensitive only to doxycycline, and it is moderately sensitive to your polymyxin group of drugs, which is your colistin and polymyxin B. Apart from this, it is resistant to almost all the other available treatment options. So we call it as a carbapenem resistant Enterobacteriaceae. Because it's a Klebsiella pneumoniae, the organism is labeled as carbapenem resistant Enterobacteriaceae. Now, many of us think for any carbapenem resistant pathogen, the only treatment options available are colistin or polymyxin. But these groups of this polymyxin group of antibiotic are associated with high levels of toxicity, and it cannot be given in all the group of patients based on the renal function, based on the neurological effects of the patient, this group of drugs cannot be administered to all the group of patients. But in spite of the toxicity, because we think there are no other option for treating this group of patients, many of the patients are on colistin and polymyxin. And whenever colistin and polymyxin is being administered, unless it is administered in the right way, like with a proper loading dose and maintenance dose, you cannot achieve clinical success. Even though with a proper loading and maintenance dose, studies reveal the therapeutic levels of polymyxins achieved is at the suboptimal doses. So clinical cure is very, very rare when you give this group of antibiotics. Now, so what would be the treatment options if I cannot use a polymyxin group of drugs, or if I can avoid this polymyxin group of drugs? How should I decide on the treatment option for this group of pathogens? So first, what are the important things which you have to consider whenever you want to decide on treating these carbapenem resistant organism? First, try to know the mechanism of resistance which is produced by this organism. Because I told you carbapenem resistance can happen by 4 mechanisms. One is production of carbapenemase enzymes, or it could be due to poron channel mutation, efflux pump up regulation, or without carbapenemase, it could be because of overproduction of or co-production of ESBL and AMC enzymes. So first, try to learn the mechanism of resistance from which we can decide on the therapeutic options available for treating these patients. Know whether carbapenemase production is present or not, which is very, very important in deciding the treatment. And if carbapenemase is present, again, try to know the type of carbapenemase produced by the organism, whether it is a class A, class B, or class T. And we always strongly recommend to do a genotyping for seeing the carbapenem resistance mechanism in this group of patients, to know the type of carbapenemase, to know first whether carbapenemase is produced or not, and if yes, the type of carbapenemase produced by the enzyme, so that it helps us in deciding the treatment option for the patient, avoiding the highly toxic polymyxin group of drugs. So these are the different classes of enzymes acting on cephalosporins, which I have outlined earlier: class A, class B, and class D. So the KPC enzymes, MBL enzymes, and OXO48-like enzymes, which act upon carbapenems. And whenever an organism is a carbapenem-resistant pathogen, it is these enzymes which is looked upon in the genotyping. And once you know the class, we know the treatment options. We know the inhibitors, which is used to inhibit these enzymes and provide a clinical benefit to the patient. Or we also know whether these inhibitors will work or not, or what are the combination drugs which has to be used for this patient. So if you see here, the class B and class D OXO48, it doesn't act on astriona. And therefore, whenever you know the carbapenem resistant organism is because of class B or class D enzyme, you have astrionam as available treatment option. But astrionam should never be given alone. It should be combined with the other BL-BLI combination drug. Why? Because it is not always carbapenemase which is produced solely. These organisms will also produce other enzymes like ESBLs, which can hydrolyze astrionam. So to protect this astrionam and make this astrionam effective for the patient, you combine it with a BL-BLI combination, which is most commonly used as ceftazidime avibactam. So for treating this class B group of drugs, the commonly available combination is ceftazidime avibactam with an astriona. Again, based on the clinical syndromes, we have, based on the sensitivity also, we have various other treatment options for treating these even carbapenem resistant organism. So carefully look into the AST report. Even in a carbapenem resistant enterobacteriaceae, if the patient is suffering from a lower urinary tract infection like cystitis, if the pathogen is sensitive to nitrofurantoin, you can treat the patient with nitrofurantoin. This is based on international as well as Indian guidelines. And the next thing to look after here is look for the sensitivity pattern of the different carbapenems. Like if one carbapenem is sensitive and other carbapenem is resistant, don't think you have to avoid the entire class of carbapenems. This disparate discrepancy in the carbapenem sensitivity is possible because not always carbapenem resistance is because of enzyme production. It could also be due to poron channel mutation or efflux pump up regulation, in which case one carbapenem will be resistant, whereas the organism will be sensitive to other drugs in the carbapenem group. So in that case, you can treat the patient with the carbapenem, whichever has been reported as sensitive. So this discrepant result is also possible. So remember, it is not always due to carbapenemase production. The next, as I told, if it's an MBL isolate, you always go for an astrionam we have as a treatment option, but astrionam has to be combined with a ceftazidime avibactam. And the novel antibiotic, which is which can be given as a sole therapy, is cefiderocol. But cefiderocol is not available in all the centers, and it's also very costly. And therefore, the most commonly available used combination is ceftazidime avibactam with an aztreonam. Now we look into the novel therapeutic agents which is available to treat these multi-drug resistant pathogens. So we have a lot of upcoming drugs which is available to treat these multi-drug resistant pathogens. But if you see, none of the agent can take care of all the resistance mechanism produced by the pathogen. So each has its own pros and cons, and they are costly and not available in all the centers. And challenges with these novel agents, as I told, they don't address all the resistance mechanism, and their activities depend on the class of carbapenemase produced by these enzymes. And most of the novel agents are not active against carbapenem-resistant Acinetobacter baumannii, which is one of the most commonest hospital pathogen. And you can expect resistance even to these novel antimicrobials. So the take-home message from my presentation is avoid misusing the antibiotic. Judicious use of antibiotic is what is needed. So always try to implement the stewardship measure. Remember 8 stewardship, antimicrobial stewardship, infection prevention stewardship, and diagnostic stewardship whenever you enter into patient care management. More than 30% of antibiotics prescribed at any point of time is unnecessary. And always remember antimicrobial stewardship, and it's better you have a microbiologist by your side. So whenever you see any reports, you have any doubt, try to establish a communication with a microbiologist so that you can clarify your doubts and you can have a better idea to treat your patients. So these are my references. And again, thank you one and all. Once again, I thank Dr. Neeraj Jain sir and the organizers for giving me this opportunity. So any queries you can post in the chat.
Yes, sir. Okay. Okay.
Yeah. Good afternoon, everyone. I'm Dr. Hariom Sharma, and I'm going to talk on QC lot verification for deriving lab mean. At the outset, I want to thank Dr. Neeraj Jain and team Melap for creating this wonderful platform of exchanging the scientific thoughts on variety of topics. And it is not only for a day or two, it is a week, diagnostic week. So commendable job, many congratulations and best wishes for future such activities. So to begin with, quality control is essential, and we need this quality control procedures to give precise and accurate results. There is a very simple logic behind this, and most of the non-wave laboratories instrument require daily testing of external quality control. And for that, we have commercially available controls which are having the non-values. And then when quality control materials are purchased separately from test reagent, then we have variety of sections in the laboratories or lab medicine. Say, for example, hematology, coagulation chemistry, biochemistry, immunochemistry, and so on. So each laboratory must verify new lot of these controls by repeated testing prior to putting them into use. This is, in a very simple way, the purpose of doing quality control, internal quality control in particular, I'm saying, is to see the right tests are performed on right specimen, producing right results, so that the clinician can have right interpretation for the right person at a very right time. So this turnaround also is maintained in a very particular time, and results reaches to the clinician. So external controls are used to test that the reagents and instruments are operating correctly. So there are two things in our setup. We have material, we have machines. At the same time, we have manpower. So we have to see that everything is working properly, and together also in a synchronized manner, they are also working properly. So what we can do, if the QC material is compromised, then QC results obtained when using it or not a validated or valid assessment of our test. By performing a new control lot verification, Sometimes it is called lot-to-lot QC testing. Prior to expiration of the previous lot of control, we can detect any degradation or contamination of our new lot prior to using it. So this is a very important exercise. We can say that the existing lot is working properly, but it is going to get exhausted very soon. We have already procured the new QC material and we are approving it, though it is validated by the manufacturer, but we are reconstituting those material, we are aliquating them in our own setup. So we have to ensure that it is working properly. So we verify this new lot before we put it into use. So this process should take place at several days. We should never make the lab mean or to do the verification of new lot in a day or two. So the exact process to use this is at the discretion of laboratory director. We can have only certain steps. First and foremost is run daily QC on the current lot number and ensure that it is in acceptable range. Run all level of new lot of controls. New lot should be run as a patient, right? And in a different QC file. If the instrument or LI has the capacity, then we can have two different QC charts. I have seen in so many labs, I should not say it like this, but yeah, this is a real-time experience for me. When we do audits of laboratories, what we see is at some labs, they take the QC material of the new lot and run it on the, like the previous QC material, and they see the results with their existing QC values. Whatever internal quality control they are using, level 1, level 2, whatever lab mean or manufacturer mean, they are running their present control. The new control is also verified in the same range. So that mistake is not acceptable. So this thing should not happen. The new lot shall be treated as a separate one, and we shall see how we will verify our performance with this for the new lot. Record the results and do the algebra. Repeat the above steps. So there are two options. Either we spread it on 20 different days, or we do at least minimum 5 different days. Compare the results of new control with the manufacturer's expected control range, which is always present in the kit insert, number 1. Then laboratory director or technical consultant must review and approve the study before the QC lot, new lot is put in use. Then the QC package insert, we have to put it on the box that yes, it is in use, put the record. So this is, good document where we have lot-to-lot verification like this. But here one point is quite important, that we are entering we be sure to enter the new QC range into instrument whenever it is applicable. So this new QC range for new lot has to be derived beforehand, and lab should not make any error in entering it once the lot is changed. So suggestion for corrective action. When we run a control, when we are testing the new lot material, why we expect that all the data or all the points will come in the acceptable range? There can be some outliers. So what we have to do with those outliers, how much we can omit, this lab management, lab director and the technical team should sit together and decide. So we have to verify the status of current lot number of control. If there have been recent shifts or trends, the instrument may need calibration before proceedings. This is again a very crucial scenario. So we must calibrate our instrument, confirm that all required calibrators and maintenance have been performed, mix and rerun the control or repeat the testing with new vials of control. If the things are not getting satisfied, notify the control manufacturer and then take the appropriate action. In some cases, QC material is unassayed. And but this scenario was a previous one. Now we have asset control, but this unasset control are also one option. In most cases, there will only be target mean value listed for each applicable instrument. In case of unasset control, each laboratory must establish their own QC range prior to use. As with asset control, this processes should take place several days before the control lot currently in use either expires or run out of stock. For asset control and unasset control, the situation is a little bit different. The biggest difference with unasset control is that laboratory will need to collect more data to analyze. So we are not using unasset control, we are using asset control in order to avoid all these procedures. So there are exact processes to use, and what are these steps? Run daily QC on the current lot number and ensure that it is in the acceptable range. Run all level of new controls. New lot should be run as a patient. Different QC file should be prepared for that. Again, I would like to repeat here, make 2 LJ graphs. So during this period, laboratory should have 2 LJ graph, one that you are already running and second LJ for the new control lot or that new material that you have received. Now, for this new control lot, you have to use manufacturer mean and SD value which is there to plot the graph. Record results, repeat the above steps at least 20 times over 5 days with different operators. A minimum 20 data points are required to achieve statistical significance. So please pay attention. Here what the standard is saying, include different technicians. In many labs, it is a standard practice that there is one technician, he'll be doing the QC work. And in any unavoidable circumstances, if this technician is not available in the lab, then the system gets paralyzed. So the more number of technicians should be involved in this process to avoid such complications. So we have variety of different operators, different technicians. We have material and we have different machines in the lab. If the setup is big, then we have to test it on those different machines by different people. Using the collected data, calculate following things. We need to calculate mean, standard deviation, and CV percent. Evaluate your data. Is it different between the calculated mean and expected manufacturer's mean? Then a good target is having your mean fall in 1 SD of the manufacturer's mean is our standard practice. So we can see if it is falling in 1 SD, we are safe, we are happy, and we can carry on our laboratory work. Yeah. In case of any adverse unacceptable condition, we need to address the issue to the QC manufacturer. And also we can review the cumulative peer group that if in any such things are also encountered at their point. Then calculate a second SD based on the historic or peer group CV. So lab can have one good practice that we can create our own data pool and we have our historical mean, historical SD and CV percent. And same time, it is a good practice to review it our peers. Establish control range for new control. Then 2 SD limits we have to determine, 3 SD limit also we have to determine. And then we are ready to plot our LJ graph. The laboratory director or the consultant supervisor must review the results. And on the QC package insert, we have to again record the dates and use it. This is an example where we can have a good sheet for our QC details. We can mention the name of the instrument, which are the analytes we are performing in this particular instrument, and instructions. So manufacturer instructions, or we can have a what we call WDIs, work desk instruction, in a very concise and local vernacular language. So the staff which is going to use can record the things. Then daily QC we have to run with old and new control. If QC fails, document corrective actions should be recorded. And what I have learned so far in the new control, when we are running, at least we can omit 2 to 3 outliers. So we have to gather 20 data, and if 3 are out of control range, and once we rerun it and it comes into the control range, then those 3 data should be omitted. So total 23, 3 are rejected, and we are gathering 20 acceptable data points. Then compare the results with the manufacturer and the same procedure what we have talked earlier. This is again one good example where we can record our results and see that data are calculated properly and it is evaluated. Also record the comments if these results are everything in now okay, acceptable. Then our corrective actions, if in case outliers were there, then what corrective actions lab did. So these comments should be very meticulously designed and entered into this data sheet. And then finally, it is reviewed and approved by laboratory director or QC head with date and time, so that every single detail is available. In case of any adverse event, we can go back and refer this sheet and come to a conclusion what went wrong. Okay. So here what we can see is what we do with the new lot. So we are always running it parallel to the old lot. In technical terms, we call it parallel testing. So this is NABL 112 is very clear about it, that when the lab is doing QC for existing lot, it is run on the lab own mean, and then the 1, 2, 3 SD limits are decided based upon the lab's mean. But when the running lot is going to get exhausted and new QC material is procured, we should not wait till the old lot expire and all of a sudden we start on the new control lot. Beforehand, laboratory has to prepare lab's own mean in advance, and this parallel testing, that's why become very important. But now the practices are somewhat different, because there is one part which is the standard. This part refers to the most strict guidelines. Second part is the commercial aspects, and lab has to deal with both and have a balance. Now the situation is very critical to those labs which are small or medium size, where only routine parameter they are getting good number of samples, but other than routine parameters or some special parameters, the lab samples are not adequate and control material is expensive. Now what we should do? This is a challenging situation where we have different solutions and we have to think about that. All right. So always preparing the lab's own mean in advance for a new lot may not be financially viable for laboratories. So this practice we have to see in couple of options that we are going to discuss. So old or running lot is run in assure that system is stable. So that we are using for patient result reporting, and validating the data for new lot is also done in parallel to the old lot. So ideally a minimum at least 20 measurements are recommended, nothing less than that. If the lab has affordability, if they are doing it for all the parameters, nothing like it, I tell you, nothing like it. But yes, for those parameters, they can establish the mean, standard deviation, LJ charts are prepared very well. And then once everything goes well, it is acceptable, we can put the next new lot into practice. Now, what if lab does not have time, resources for 20 parallel run? So here we come to that situation. As I said, financially it may not be viable for even larger labs also. So what we have seen is labs initially say, okay, they are practicing it, but on the other side, it is not possible. So only manufacture mean and SD is used for such parameters. The solution here is very simple. What we can do, either you collect 10 data points for the new lot material and derive a temporary mean. And for this purpose, what we can do is, as I said earlier, that we have our own historical SD. So from your 1 year QC data, or some labs, very standard labs, sorry, they use 2 year data of controls to derive their historical mean, historical SD and CV percent. So lab can use the 10 data points and they can use their historical SD initially. Once the additional 10 data points are added, you now have 20 data, prepare a mean and shift over. Second situation where lab is getting samples on very occasionally, maybe once in a week or twice a week. In such cases, what to do? Standard says you run the control when you are testing the patient sample. This is one thing. But what to do, how to prepare the lab mean for the new control material? So for initial 10 data points, you can use manufacturer mean and your lab's own historical SD. This is another scenario. So use the manufacturer mean for this new lot for such parameters where you are not having adequate samples every day. For such control material, prepare a temporary mean by using manufacturer mean and then use your historical SD. Once you have these 10 data points, use the control, and then once the more data points are present with you, you can create your final mean. So you have a temporary mean which you can switch over with 20 data to your further mean. And SD means dispersion of capture of variables of the lab. So this standard deviation, we are having all the variables into account and we have our own mean. So once the historical SD is used by the lab, you have already incorporated a large number of variables over a larger period of time, maybe 365 days or more than that. So using the manufacturer mean with your SD for such parameter can help you to save your material, QC material. So hence using this CV on a reasonable accurate mean for 4-5 runs will alert you both inaccuracy and imprecision with minimum false alerts. The initial standard deviation value obtained by the calculation may be replaced with a more robust estimate when data from longer period of stable operation becomes available. So what is the recommendation for parallel testing by NABL 112? CBC and coagulation, run new QC 4 to 6 data point in 2 days. It depends on the stability also. Clinical chemistry 2 to 3 times a day for 2 to 10 days or gather 20 data points. Qualitative and semi-quantitative, then at least 3 patient samples, negative, low positive, high positive, should be run along with old and new lot. So these are a few steps for parallel testing. We don't want to repeat it again. But yeah, the important point here is handle the new lot number material in the same manner to encompass that the normal day-to-day sources of variability. Inherent randomness is incorporated. Then collect 20 data points and then prepare your mean SD 1, 2, 3 and even 4 SD limits also can be calculated. Prepare the algebra and then we must see how it is plotted, nothing new in it. Then draw the following lines across. This is algebra. Now we have automated softwares. So what may happen once we have out of control situation with us? All right. So this can be resultant of random or systematic error. So there are 6 commonly used waistguard rules also. These are warning rules, mandatory rules. So when such errors are present in your system, this waistguard rule will help us, and we can see that these systemic errors or they are the evidence by change in the mean of control values, whereas random error is any deviation away from the expected results. So very easy to understand these 2 errors. Then we not need to discuss, these are different warning rules. 1, 2S, warning rule 2, 2S. Then 4, 1S rule, it is very interesting, but normally I have not seen the laboratories practice this rule in their day-to-day activities, QC activities. The mandatory rules are 1, 3SD. It is the situation we cannot overlook, and we have to address it immediately. We have to stop the patient sample testing and resolve it. Once the results are accepted for QC, then only we can regain our patient sample testing. Then this is mandatory R4SD rule. It is only applied when the IQC is tested in duplicate. This rule is violated when the difference in SD between duplicate exceeds 4 SD. But we normally don't have this practice. We don't run IQC sample in duplicate. But yeah, this is one scenario I would like to just show right now. So here we can see what are the factors affecting the quality of results. It can be the educational background and training of laboratory personnel. I would again and again put lot of pressure, emphasis on the technicians who are actually running the laboratory's QC program. They are so much busy every day in the patient sample testing, and they hardly have training or adequate training for the QC. So it is recommended that at least twice in a year, same training or repetition of that training should be done. There is no harm in repeating those things, so that it is always in their mind. Condition of the specimen is very important. Temperature and humidity. Sometimes we are storing the QC material in the cold storeroom or in the refrigerator, and it can capture some moisture. So how carefully and meticulously you design your SOP for storage, aliquating and storage of your QC specimen, please ensure to avoid this. The control used in the test run is important. Reagent, equipment, transcriptional error. Now most of the labs are shifted to automation, so these problems are not there by and large, and then some reporting of result error may occur. These are the options for QC pool. QC material must be closely matches the specimen. This is our top priority, and we are using that same. Then commercially lyophilized pool material, commercially stabilized liquid pools, frozen patient pool specimens are the options. The advantages of this material, which is commercially available: less turbidity, more stability, smaller imprecision, but the cost is high, then that we have to bear if we want to give the quality. Then we have another option, frozen patient pool specimens, like for pre-tested for HIV, HPSAG, etc. Patient serum is more frequently used here in microbiology, so we have to be very careful. What care we need to take during reconstitution? Do not mix too quickly or too vigorously. This is one thing. So these steps of preparing your QC material, the water quality also should be very carefully labeled, and see it is used in preparing or aliquoting the QC material. In frozen liquid, make sample 6 times by inversion. So these are the standard protocols lab has to put as there as the work desk instructions, WDIs. So take home message here is very simple for quality control approaches. Every lab is now the one who is NABL accredited is compulsorily doing it. And those who are not accredited, but at least QC practices are there in use. I have seen in our country now, because we are now a quality driven country. And this approach for quality control is very simple. We have to use the best QC material available by incorporating the cost of using the IQC material. But don't forget to prepare the lab mean before you put the new lot into practice. There are at least 3 approaches. In case of routine parameter, just do parallel testing with the running lot and the new lot. And with 20 data points, prepare your own lab mean and SD and put it for in use for the new lot. In case of some parameters which are irregular, only collect 10 data points, and from the 10 data points, temporary mean can be prepared. And in rare parameters, use manufacturer mean and your lab's own historical SD, and take 20 data and then prepare your mean. So these are the 3 approaches, and here I rest my presentation. Thank you very much for your patience listening, and thank you organizers once again.